Okay, let's get started for day 2. Again, we've got a live crowd and also a video crowd. Welcome. Because we do have a smaller group, I'm going to find, similarly to yesterday, that we're going to get through a lot of the information quicker. So rather than sticking to an absolute formal schedule and try and stretch things as I was doing yesterday, what I'll do is go through at a standard pace for the information, and then we see where we're currently sitting at for the afternoon sessions, and I think we will be able to add a second model. For those online, or for those who haven't met me, I'm Dr. Christie Sept. I'm the Clinical Director and Global Medical Trainer for Dermapen World. The accent's Australian, but I've been based in France for a very, very long time now, and I've specialized in microneedling going on some 22, 23 years. The schedule for today is more advanced in regards to what I've done is taken excerpts of our most technical masterclass that we deliver in Dermapen World, which is called the Dermatological Masterclass series. The design of this originally was created in conjunction with the University of Tehran in Iran, where we wanted to fill in the gaps where medical practitioners were missing out on aesthetic information for their dermatological and for their aesthetic procedures. So with this, we created a whole 2-week master series, which explored everything from hyperpigmentation, hypopigmentation, rosacea, alopecia, acne, then moving into all types of scars, and then adding in more topics to this series to basically look at the complete lowdown as to why the patient has this condition, triggers and activators, looking at solutions, looking at combination therapies. So exploring above and beyond just the Dermapen World realm, but also assessing in regards to the patient's lifestyle, genetics, diet, but also medical indications that we take into account as well. For today, what I've done is separated some of the key topics and then created a mini version. So we're going to begin with scars. Scars is going to cover all aspects, including post-acne, atrophic, hypertrophic, medical keloid protocols, and then moving into burn contracture scars. So there will be drug combination therapies involved. We will then move into the very quick topics of PRP and also mesotox combination therapies, which will then lead me into a further mini dermatological masterclass topic for alopecia. I think for ease, the most simple combination therapy for this, for the Irish market, is going to be PRP. But there will also be some drug combination therapies involved. We will then finish up with the topic of acne this afternoon, looking at this with a very, very innovative new approach. I think the problem with the acne market is that so many practitioners, but also so many patients are relying on a lot of misinformation. And it's very easy to go online, it's very easy to look at social media, and this misinformation becomes further and further fueled and fueled and fueled. And you'll be surprised as to how many common practices, even promoted by physicians and through aesthetic practitioners, that are in fact making the acne condition worse. So let's get started with our scar topic. We will break at around about 11:30, and then again, we will have a full lunch break for an hour at around about 1:30. So we'll see how the time takes us. I'm just going to, are you able to push into full screen mode for me on the laptop, thanks? It's just in the very bottom right corner. I can do that. It's just talking to the projector. Perfect. So our first mini master topic today is skin innovations with Dermapen 4, DpD dermaceuticals, and also drug combination therapies, being able to treat all types of scars with pinpoint precision. First of all, I really want to establish and continue on with our story of the wound healing response and proliferation to establish exactly what a scar is. A scar is where we have trauma to the skin but your trauma must exceed from the dermis above and beyond. So if your trauma is only localized to the epidermis, you will not get a scar. So just to remap up some of the information from yesterday, we have epidermis, we then have dermis, we then have hypodermis. The reason why you can't get a scar in the epidermis is because there is no collagen-producing cells. So by definition, a scar is an abnormal production and an abnormal collection of collagen. In the dermis, your fibroblast, or your collagen-producing cell, accounts for some 85% of composition. In your hypodermis, your fibroblast accounts for around about some 5 to 7% of composition. As the most abundant protein found in the human body, collagen is not just found and present in the dermis and the hypodermis, but you will also find it in muscles, ligaments, tendons, and also bones. So this will be an area that we will take into account when there is fusion of this protein, particularly when we look at a burn contracture scar. So by definition, your trauma cannot be localized to the epidermis because your key cell is a keratin site. So in order for the trauma for your typical scar, it's working from the top down. So we have the trauma, which now takes us into the skin. Any trauma from the dermis and below, which then facilitates an imbalanced or unregulated proliferative wound healing response, is then going to activate your scar response. When there's trauma, whether that is ablation, whether that's burning, whether that's ongoing damage, whether that's through infection, whatever that may be, it activates, as we covered yesterday, what's called pro-fibrotic growth factors. And these are the growth factors that will determine abnormal collagen deposition. This includes a family called transforming growth factor beta 1, transforming growth factor beta 2, and heat shock protein 47. So these, shall we say, bad growth factors become activated when there is major trauma. And the response of these growth factors is then to create cicatricial healing. Cicatrice or cicatrice is Latin for upside down. So essentially, to try and re-epithelialize this area of trauma, we see the abnormal over-deposition of mature type 1 collagen to try and re-epithelialize that trauma as quick as possible, and then this now contributes to an abnormal collagen deposition. Despite the fact that we will commonly associate, particularly for keloids and hypertrophic scars, more for a darker skin, Fitzpatrick 5 and 6, typically of African ethnicity, the reality is, particularly for the keloid story, that there is just as high risk for a Fitzpatrick 1 of Celtic or also Scandinavian descent. Irrelevant of this though, every single person can be scar prone. It affects all ages, it affects all ethnicities, all Fitzpatrick skin types. Because collagen is more abundant in a younger person, so our collagen production depletes at a rate of around about 1.7% a year from the age of 20 onwards, you'll find that most scars that you experience, generally you accrued during childhood or early adulthood. So the older you are, it's generally going to be a little bit harder to scar. Particularly for wound healing following an operation or following any major trauma, if there's infection, if there's wound tension or bad post-operative care, this can contribute to scar tissue formation. So in all good intents and purposes, even though a patient may not be the perfect demographic for scar tissue formation, if they don't have appropriate wound care, this will contribute to unexpected scar tissue. We're going to categorize our scars into 3 areas. It's either going to go down, so it's going to divot, we call this an atrophic scar, or it's going to go up, and we refer to this as a hypertrophic scar, or it's going to fuse together, and we will refer to this as a contracture scar. Having a look at our options. Atrophic scars, the most common reason that we generally see this are post acne scars. It's estimated that some 30% of patients who have experienced acne worldwide will then experience post-acne scars. So an atrophic scar is where we have a divot or where we have an indentation within the skin. For our acne topic this afternoon, I will then explain why this occurs as part of the acne phenomenon. The first consideration that we have at the top here is a rolling scar. A rolling scar, the only reason why you're going to get this is following acne, generally stage 2 or potentially stage 3. It's a superficial wave-like undulation that will follow the acne condition. When the acne becomes more serious, particularly acne stage 3 or acne stage 4, this can then be identified by a boxcar scar, which is a square-like indentation into the skin, as also seen here. Following this, particularly following acne stage 3, but this can also have a trigger, which is seborrhea, the natural genetic predisposition to have an oilier skin. So it is a slight form of a dilated pore. We have an ice-pick scar. And this is a triangular-like indentation into the skin. Visually, an ice-pick scar is going to look more severe, deeper, and more aggressive by comparison to a boxcar scar. This is not necessarily the case. And the reason why is because of the V shape. It's going to hold more shadow by contrast to the boxcar, which is able to illuminate more light. So you're generally looking at the same depth within the skin. It's just the shape makes it look more severe. The only reason why you experience rolling boxcar or ice-pick scars are post-acne. No acne, you will not see these types of scars. There is another category that we will commonly refer to as pock marks. And the most common form of pock mark is called an anatodermic or anatoderma scar. What characterizes a pock mark is that you have a rounded indentation into the skin, but it will be isolated. So as opposed to rolling scars, where you have multiple rounded indentations, for an anatoderma, you'll find that these are more localized and separated. The two traditional reasons why these occur, the most obvious is smallpox. But now that this is no longer such a big problem, though it is still a possibility, you will find that patients who have smallpox inoculation on the arm generally will also be followed with an anatodermic scar. The second most common reason, and this one we thought we had under control, but it is coming back with a vengeance, and that is the STD syphilis. So going back historically, you may recall paintings of high society back in the 17, 1800s, and the use of using beauty spots or marks on their face. The whole purpose of this was to actually cover up syphilis scars, which are anatodermic round scars. So these, once the syphilis becomes worse and worse, affect not just the pubic area, but will also affect other parts of the body. The most common reason, however, why you will see an anatodermic scar is chickenpox. So depending on how severe that was throughout childhood, will then determine how severe your anatodermic scars are. So by comparison to rolling boxcar or ice picks, which are mostly exclusive to the face, although it can occur if there's been acne on the chest or back, an anatodermic scar will appear anywhere on the body, so long as there's been a condition of chickenpox, syphilis, smallpox with this. But from our areas of indentation, we now move into a new category, which is called hypertrophic. So all our post-acne scars and anatodermic are atrophic. We now move to hypertrophic. Terminology for this is extremely difficult. And the reason why is because, particularly for a market where keloids are not so common as we see in Ireland, A lot of practitioners, but also patients, get confused between what is a hypertrophic scar and what is a keloid scar. To make the process a little bit confusing, all keloid scars are hypertrophic, but not all hypertrophic scars are keloids. So very quickly, that is a hypertrophic scar, that is a keloid. So for the demographic here, you will find that for most patients, we're talking about a hypertrophic. So with a hypertrophic scar, what we have is an initial wound, and from that wound, we then create cicatricial healing, so upside down. You end up with collagen production within the epidermis, and then it begins extending up. But for a traditional hypertrophic scar, your extension and overgrowth does not extend above and beyond the borders of the initial trauma. So you'll find that it is relatively neat in its appearance and a similar shape to what the original trauma was. By contrast, for a true keloid here, what you have is an overgrowth that extends above and beyond the site of initial trauma. The keloid can also be itchy. The keloid can also be sore to the touch, and the keloid can continue on a process of development even after steps have been undertaken to try and remove it. All keloid treatments must be performed only by a medical practitioner because you will require a drug combination therapy. For a stabilized hypertrophic scar, it is possible to use Dermapen utilizing an imprint technique to then enable its reduction for this. The reason why you'll get this is trauma. So it is possible to get a hypertrophic or a keloid scar following acne, but it's possible particularly following any type of trauma. So in this case, this is from an ingrown hair on a patient's skin, and then in this case here, we see a common C-section scar. The final area for consideration is a contracture or burn contracture scar. This is where we have fusion. So in this case, due to burning of the skin, this has now created a fusion and abnormal collagen deposition that has melted together the skin, muscles, ligaments, and tendons, and in some cases that can go down to bone. So with this fusion, you're going to have a combination of both hypertrophy, but also atrophy within this area. So how you will diagnose is not just visually, but also touching the area to determine where we see the ear has fused into the neck area, but we see atrophy around the bottom neck, and then we see hypertrophy where we see the bands, which are holding the two areas together. So this is going to require a multiple approach to try and treat and target both the atrophy, but also the hypertrophy, and also the hardness of the physical scar itself. Looking at definitions and looking at categorizing systems, I touched on this categorizing system yesterday, and although it's primarily focused for post-acne scars, what I want to do is use this system to update techniques, but to also help categorize the severity, particularly of post-acne scars, which are the most common scar that you're going to treat in clinic. The reason why is with such an increase of acne on the market, and with an estimation of 30% of acne patients experiencing post-acne scars, there is a lot of depression and a lot of association with scars where patients believe that they are helpless, that there's no hope for them. So I really want to determine what is going to be easy to treat, what's going to be moderate, what's going to be the most difficult scar to treat. This system here is called the Goodman-Barron categorizing system. Goodman is a plastic surgeon based in Melbourne, Australia, and Barron is a surgeon based in the USA. In 2006, when they wrote a clinical paper on fractional laser and treatment and revision of post-acne scars particularly, they created a system to then determine how severe the scars were. Then this would help assist in creating a treatment program, how many treatments would be required, and how expectations would be met for the patient. A Goodman-Barron 1 is where we have a color change, but not a contour change. That's this patient here. So this patient's going to look in the mirror and say, I see bad scar tissue following my acne. If you were to look at this skin topographically, you would notice that there's no contrast of atrophy, no contrast of hypertrophy. The issue is in fact color. The issue is not contrast. So simply, if you were to put on a thick layer of foundation at the right color, you would not see any of these scars. So these macules are a color problem, they're not a contour problem. So we see this as being the most mild or the easiest to treat of scars. For a Fitzpatrick 4, 5, and 6, as we see with this patient, your macules are going to turn brown. For a Fitzpatrick 1, 2, and 3, your macules are going to turn red. So with this, we understand that because we're treating more superficially, because it's a color issue, this will be the easiest type of post-acne scar that you'll be able to treat. As such, with Dermapen, you will use your gliding technique. So because there's no contrast, you'll be able to apply your energy collection mesoglide and use your standard technique of vertical, horizontal, diagonal 1, diagonal 2. This is a Goodman-Barron 2 here. You look at the before and after and you think, what miraculous treatment has this patient had to deliver such a phenomenal response? It's called makeup. So if you can apply makeup and it covers up the bulk of your scars, if you have flattering light, so it's nighttime, if you can put a subtle filter on your social media, or if lighting can be adjusted to give you a completely clear skin and all of the appearance of your scars is removed. For a male patient, if they can grow a beard or if hair can cover up the area, you're dealing with a Goodman-Barron 2. So what this means is generally you've got a mild contrast of atrophy. So this is typically going to be mild rolling scars and maybe some very superficial boxcar scars. Because your contrast is mild, your topographical contrast is not so different, it means again you can still implement your standard gliding technique with your Dermapen 4. A Goodman-Barron 3 is where you have a moderate atrophic or a moderate hypertrophic scar. A Goodman-Barron 4 is where you have the severest atrophic or hypertrophic scar. What's the difference between these two? So we understand that at a 2 meter distance, you can still see these scars. At a 4 meter distance in the dark, you can still see these scars. Makeup is not going to get rid of it. A filter is not going to get rid of it. Good lighting is going to be difficult from a few meters to make these completely disappear. However, with Goodman-Barron 3, if you were to stretch the skin and the scars were to flatten out, we would call this number 3. But if you were to stretch the skin and the scars still don't flatten out, this is a Goodman-Barron 4. So when we look at the most severe, it's when even when you try to stretch, contort the skin, it doesn't flatten. So this is going to require the most amount of treatments. This is going to require a multiple technique synergy of solutions. But with a Goodman-Barron 3, we understand that for your treatment with Dermapen, you're going to need to support the skin to physically treat and target that scar three-dimensionally. So what's going to change for treatment is for Goodman-Barron 1 and 2, glide technique. For Goodman-Barron 3, you may be able to use glide technique over the general area, but you will need to use imprint technique with Dermapen over specific clusters of scar tissue. For Goodman-Barron 4, you will predominantly be using imprint technique to mechanically break up the scar tissue at multiple angles. So here's our refresh for our glide technique. You're going to use this for a Goodman-Barron 1, 2, and early 3 for generalized rejuvenation when you have a mild to moderate contrast with this. So slightly atrophic slightly hypertrophic, can flatten out when you support the tissue. There's two options that you will use for your MG collection. Number one, for collagen modulation, will be the MG collection RAS. But if you are going to incorporate PRP as part of your procedures, you will still need a base lubricating agent, and then it's going to be the MG collection HA35. PRP does not have enough lubricating capability to facilitate a smooth, easy glide. So if you just use PRP with Dermapen, you're going to find resistance, which equals pain, which is going to equal track marks. Your success of your glide technique is fastest speed, which now means that you can operate at fastest gliding technique of vertical, horizontal, diagonal 1, diagonal 2. So as such, you will need to turn your Dermapen up to speed 4. Speed 1, trying to use glide, it's going to drag and create resistance through the skin. Speed 2, again, resistance. Speed 3, we can create more comfort. So speed 4, which is 120 revolutions per second, which is now going to deliver an unprecedented 1,920 puncture channels per second into the skin. You're going to use a striping technique. So again, vertical, horizontal, diagonal 1, diagonal 2. You must draw blood. If you do not draw blood, then your needles are not deep enough to target into the dermis or hypodermis, which is where these types of scars are localized. So to repeat from yesterday, there is no such thing as a baby Dermapen procedure or a starter procedure where you go in very lightly and very superficially. You either hit the fiberglass and have a direct interaction and stimulation for a result, or if you don't, nothing will change. So what we will look out for, if your scar is red, blue, or purple, that is a sign that there is still some vascularity within the dermis. Your visual endpoint is pinpoint blood. If the scar, however, is very white, if it's very old, or if it's very dark for a darker Fitzpatrick, you will need to target down to the hypodermis, which means a moderate release of blood. This is what our technique looks like. So this is post-acne aspic and post-acne boxcar scars. This is our glide technique on the second cheek. Vertical, horizontal. So you can see the device is still gliding. If you were trying to glide and you found that you had a lot of resistance, this is where you may need to use your imprint technique. The skin will tell you everything you need to know, and the feeling of the pen in the skin will tell you what you need to know. So again, for our gliding technique, choose an appropriate depth. In this case, due to the color of the scars, we're looking for a moderate release of blood. Energy collection RAS applied onto the skin. Vertical movements. You can see that there is some resistance through this area here, but we're going to fix that by using the imprint technique, which I'll cover in the next slides. So a combination of the two can be advantageous for some patients, particularly because you won't require imprint technique for this patient's forehead. When you need a more localized scar treatment, this is where you can then add your imprint over the top. But these are glide patients. So this first patient here, we see a combination of rolling and boxcar scars. This is before and after one procedure glide technique. This is a Goodman-Barron 2. So if this patient were to grow their beard out, it's nighttime, flash photography, flattering light, most of this would disappear. This scar here has occurred because the patient's been in a car accident and gone through the windscreen. With this, it looks very severe. And so typically you would look at this and go, this is going to require many treatments, extensive combination therapies. I'm going to propose to you, however, if you were to put on the thickest layer of stage strength, TV strength foundation onto this skin, would the scar disappear? 90%, 80% of this scar would be completely covered. So we understand that this is a color issue. It's not necessarily full contour issue. So there are some contour issues just on the lower cheek here and just on the top here, but the rest of this area in the middle here is a macular scar. So it actually classes as being predominantly a Goodman-Barron 1, and then the physical scars themselves further up the top are going to be a Goodman-Barron 3. They will flatten out. So we see before and after 3 procedures using our gliding technique. Our imprint technique is inspired through subcision. This treatment is still performed particularly in third world countries, but also countries where there's not a lot of options for scar revision. It's an 18 gauge needle, so it's twice the size of this one here. It's inserted into the skin and then fanned to mechanically cut and break through the scar tissue. It was subcision which then led on to the development of the microneedling roller and microneedling stamp. So we understand that with these older techniques, there is some value. We can use these techniques to inspire and update with Dermapen, and this is what I call imprinting. Imprinting is not the same as stamping. Stamping, like a stamp itself, like subcision, is very practitioner dependent. With Dermapen 4, you're going to be able to change your needle depth at any point, at any time, because bear in mind that the scars are not going to be consistently the same density and thickness. Likewise, with this, with imprinting, you're going to need to hold position for at least 3 seconds at multiple angles, as we see here. So first, choose what your depth is going to be. Just because you can go up to 3 millimeters with your Dermapen does not mean that every scar is going to be 3 millimeters. So if it's not, let's imagine at 1.5. You hold in first position at a 90-degree angle, 1, 2, 3, needles out. Then re-support the skin using your hand, and then going in at a 45 to 65-degree angle, 1, 2, 3, 1, 2, 3. So essentially, you're creating a 3-dimensional aspect to mechanically break down that scar. If you're working at 1.5, if you're working at 2.5 and you find the needle stop or you need to drag through the skin, the reason why is because of cicatricial healing. So you have bound collagen sitting higher up within the skin, but you need to get to the source of the scar tissue, which is deeper down. So you may consider that you could work at, say, maybe 0.5 of a millimeter. 1, 2, 3. 1, 2, 3. Then increase your device potentially up to 1.5. 1, 2, 3. 1, 2, 3. Until eventually, when you're up to 2.5, you can then create penetration into the skin and be able to effectively treat the scar. So there's 2 ways to do this. You can either choose your depth and then operate at speed 1. So this means 66 revolutions per second, 1056 puncture channels per second. So it gives you a concentration and a precision, but it likewise avoids over-treatment like stamp would. Otherwise, if you go to your 3 millimeters or scar treatment, it's going to be 60 revolutions per second and 960 puncture channels per second. Your visual endpoint is still the same. So it's either going to be for red, blue, or purple scars, pinpoint blood, or for darker or white or very old scars, you're looking for moderate release of blood. So first angle, second angle, if you achieve your success with 2 angles, not a problem. If you need to add in a 3rd angle, not a problem. Gauge and watch, but just ensure that you are not over-treating. So this is the same patient who's been treated with glide technique first. Now we're going to use imprint. 1, 2, 3, needles out. 1, 2, 3, out. 1, 2, 3, out. So you can see that I'm re-angling the skin and enabling for a localized, concentrated mechanical breakdown. Please try and make sure that your fingers are far away from the needle cartridge so you don't risk a needle stick injury. But you can see where the patient has been treated on the other side of the face, the level of moderate release of blood that you're after. I don't recommend that you give patients a mirror for these treatments, and also that they don't film themselves with this. Some patients will find this uncomfortable to see that level of blood coming through. So I generally talk about color. So if the patient says, how's it looking? I'm saying it's great. There's lots of color coming through. This is exactly what we're wanting. The patients will find that this is no more uncomfortable than what a full gliding technique is going to be. Just bear in mind that if you do use a topical local anesthetic, you've got to be very careful of the formulation because if the vasoconstricts, particularly ester agents such as benzocaine and tetracaine, that's going to be problematic to achieving your visual endpoint. So how does my imprint technique look? This is a nodular, but it's hypertrophic and atrophic scar. So when we have a look at this type of scar, is it okay to remove what's on the board? We have essentially here like a volcano. So the skin rises up, then the skin goes down. So this is how this looks. If I use the glide technique, you're going to be able to touch the top of the mountains, but you're not going to be able to get inside the physical volcano itself. So using a combination, if required, or using your physical imprint technique, you're now able to break through the mountains, but then you are able to now get into the physical canyon or into the physical volcano center. So this now allows you an effective technique that will treat and target where you have both a combination of atrophic but also hypertrophic scars. So this is a nodular scar following acne. This is a very extended ice pick scar. This follows typically what's called acne fulminans or acne conglobata, where you have damage to multiple follicles at once. So this is before and after one treatment. We've used an imprint technique. So again, going in vertically, supporting the skin at a 45 to 65 degree angle to allow for a 2 to 3 dimensional breakdown of the scar. These patients are older, but for this patient here who's 17 years old at the time, this is just after one treatment, but also the addition of the retinaldehyde for procedure. Younger people will have a faster result, and particularly with those who are under 18, rough guide, you may be able to treat as frequently as every 4 weeks. So this is an imprint technique for a trauma scar that occurred after too much alcohol and stairs. So with these, we see that we can achieve success by simply changing your technique and to update. Looking at combination therapies, what options do I have based on the type of scar that you are dealing with? For an atrophic scar, your key MG collection will be the RAS. If you're going to use a combination therapy such as PRP, you will use the MG collection HA35. On an appropriate skin type, which means a Fitzpatrick 4.3-ish, 4.2-ish, someone with no risk of post-inflammatory hyperpigmentation, you can use the Uber MD. I did not introduce this peel yesterday. This is an update to a traditional cross combination therapy. Cross in this case stands for chemical reconstruction of scars and striae. So where appropriate, you can use this as a combination therapy on an appropriate skin to now create both a mechanical rejuvenation, but then also a chemical rejuvenation of the skin. A post-acne scar is an atrophic scar. So you have the same options, MG collection RAS and the option of Uber MD. For a stable hypertrophic, this can be treated by a non-medical practitioner. You don't want any chemical stimulation that would then further enhance further collagen production. So this is just Dermapen and your MG collection RAS. If it's unstable, you will require drug combination therapies. So this can only be treated by a doctor, not by a nurse for the Irish market. You're going to need to prepare the unstable hypertrophic or keloid scar, firstly with a steroid injection. The steroid injection that is preferred is called Kenalog or Kenacort by brand name, and the physical chemical agent is called triamcinolone acetonide. This is the most researched in the market. If you are not able to access triamcinolone acetonide in the market here, you can actually use betamethasone or methylprednisolone, but most of the studies for scar reduction worldwide are relying on triamcinolone acetonide. You prepare first with an intralesional injection. You will then dermapen with your MG collection RAS. This will allow and facilitate movement, and then you will use an antimitotic drug. The antimitotic drug is called fluorouracil or 5-FU. The common brand for this is referred to as Effidex. With this, you will intralesional steroid first, dermapen second, I will go through protocols, and then apply the fluorouracil over the top. For a burn contracture scar, depending on its shape, depending on its topography, you may be using a combination of unstable hypertrophic keloid protocols and maybe stable hypertrophic protocols and maybe some atrophic scar protocols. So you've got to take into account the changing topography and the waves of the skin that are physically created. So a stock standard dermapen procedure for post-acne or atrophic scars. Number one, cleanse the skin thoroughly, ensuring that there is no residue. If you're treating on the body, you can use the microderm exfoliant as an effective cleanser, but for the face, always the tri-phase cleanser. You then need to disinfect the skin. The CliniPrep solution, spray it on, wait 15 seconds, do not rub this onto the skin, otherwise you deactivate the hypochlorous. Your MG collection in this case is going to be the RAS, reversing aging and scars, 0.1% of retinaldehyde. If you want a more premium procedure, which means that you're going to charge more, you could substitute with the MG collection HA35+, which again is 0.1% retinaldehyde, but also 35 milligrams per milliliter of hyaluronic acid, calcium phosphate technology, and also telomere technology. With your dermapen, you're going to use a variety of techniques as required based on the scar, Goodman-Barron system of gliding or imprinting. Then move on to the next area. Once you've achieved your desired visual endpoint, which is either pinpoint blood or consistent blood, don't clean the skin. Apply your post-operative mask immediately over the top. If you're going to treat a body area, what I suggest is grab the cloth of the mask, wring it out so you've got a gel liquid, and then massage that over the treatment area. Wait for up to about 15 minutes, but you can leave that for as little as 7 minutes in a medical environment. And then for a more holistic spa approach, you could leave it up to half an hour, 45 minutes. If you are going to use an LED over the top, you will need to use one of the LumiFuse masks, which will physically allow the light to penetrate. So you can't use a classic highly active 3D sculptured mask because the cloth will block the light from coming through. Your post-op care is always for scars. Vitamin-rich repair, followed with an application of scar cream, 7 types of re-epithelializing silicones, and then you can put your cover recover over the top. My advice, if you have a Fitzpatrick late 4s, 5 or 6, the scar cream features zinc in addition to silicon and in addition to safflower seed oil hyperoyal esters, which are tyrosinase inhibitors for post-inflammatory hyperpigmentation. When you put zinc on a darker skin, it makes the skin look blue. So you need to be conscious of this so that the patient does not walk out with a blue face or blue scar. So I suggest that you grab one of the coverware covers in dark color and blend this through just to tone down the zinc and to tone down the blue reflection that it can create, particularly on Fitzpatrick late 4s, 5 and 6. So this is our standard treatment. This is the same patient as before. MG collection applied onto the skin. Get the patient to support, the bottom left. 34. Horizontal. Down one. You can see that this patient was using not only that have scars, but also have acne. So this is a good patient where you can actually alternate the treatment depths. So now we're going in with glide technique after, sorry, our imprint technique after our glide technique. So localized, precise, and we'll specifically treat these areas of bound hardened scar tissue. So we see in this case, based on the color, but also based on the severity of the scars, that you're going to be using moderate blood as your visual endpoint. So again, MG collection over the treatment area, support skin, vertical, horizontal. There's no topical anesthetic used in these patients. You see how the Dermapen glides very well over this area. It's an easy glide than what it was on the shoes. So when you feel that resistance or you feel that it can bouncing, that's an indication that you're going to need to use your imprint technique. So multiple angles as required until you feel that the needles penetrate easily and until you achieve the desired visual endpoint. So with a standard Dermapen, atrophic scars, MG collection plus Dermapen, this is the types of results that we see. So this is rolling and box scars following 2 procedures, glide technique. These are metadermic scars, so they've also post-inflammatory hyperpigmented. So these are from chickenpox on the patient's face, but you also notice that they've got a slightly brown tone to them. So the practitioner has combined in not just the hyaluronic acid that we see in the MG collection, but also the bright light, which will reduce any hyperpigmentation. This is one procedure, gliding technique. Typically known as cross technique, this was developed by a leading US dermatologist way back in the 1970s. And cross stands for chemical reconstruction of scars and striae. So the idea of this is that if you place a burning chemical agent into the area of atrophy, then that burn will create a controlled trauma. That controlled trauma will then instigate controlled collagen production and then will begin to fill the area of atrophy. This typically used to be done with phenol, so that would take it down to a deep chemical peel, or traditionally done with a very, very high percent of trichloro or TCA, acetic acid, or alternatively could be done with very, very high percentages of salicylic acid or even resorcinol. There's challenges to traditional cross technique. And if you've worked with medium depth chemical peels before, you'll find that not all patients react the same way. And you'll also find that even the same patient doesn't react the same way from treatment to treatment. For example, if you treat the patient today and you apply the peel, they might frost instantly. Perfect, that's your desired visual endpoint. But next time you see them, you put one coat on and they don't frost instantly. So then you need to put another coat on. If it doesn't frost, you need to put another coat on. If your frosting then goes from white to yellow, you've then gone way too deep and created a deep chemical peel, and that is going to be extremely problematic for you from an infection perspective. So how do we now formulate so we can deliver an effective cross technique, but it frosts every time on everyone in every place, predictably, reliably, safely? This is the Uber MD. The Uber MD is an innovation that it uses a new category of acids that's called a beta lipohydroxy acid. Beta lipohydroxy acids have some similarity to what you see with salicylic and with TCA, but with this, they will activate further strength and durability, but create a very, very predictable outcome. In this case, the ingredient is called caprylyl salicylic acid. When you blend this in with TCA, it means that for every patient, every procedure, every time, it frosts on the first application. So this avoids you having to do 3 applications on some areas of atrophy, 2 applications on others, and then begin to lose your count, and then over-apply and go too deep. You can only use this combination therapy on a Fitzpatrick 4.2-ish, 3-ish, 4-ish, 5-ish, and below. So the reason why I'm giving you those averages is if your patient has a risk of post-inflammatory hyperpigmentation, this is not your product for you. So I generally will ask a patient, if you squeeze, what color does it go? Does it go brown straight away and remains brown for a few months? Or does it go red and remains red for a week or so? So when looking at lower Fitzpatrick skin types with no risk of post-inflammatory hyperpigmentation, this peel combination therapy and cross technique only works for atrophy. Never use this on any hypertrophy, and it's probably not going to be your best combination therapy for a burn contracture scar. So you're looking for rolling, boxcar, ice pick, and anatoderma scars, so all atrophic. This also works as a good technique that you can use for your anti-aging procedures, because a deep righted or a wrinkle is a deep scar. So similarly, you can actually use the cross technique to instigate a chemical controlled response and reaction to then create a chemical collagen activator. This can also work for trophic stretch marks. So you do have versatility for deep wrinkles, which is in this case here. You can see where it's been applied, but then also for atrophic stretch marks and all types of atrophic scars. Because you're burning the skin, you create a process that's called coagulative necrosis, which means you're cooking the protein. You're cooking the protein of keratin, and in some cases, you're cooking the protein of collagen. That's going to create this white frosting here, particularly for cooking of keratin. When you see yellow frosting, it means that you have gone down into the dermis and you're beginning to cook collagen or fibroblasts itself. This is too deep for an aesthetic practice. For a medical practice, it's a possibility, but you're going to need some major wound management. When you create a chemical burn, you will create a full wound healing response, which means there's going to be an eschar, or an eschar is a scab. That scab typically forms on day 2 to 3. Do not touch it, do not pick it, do not scratch it. Keep it nourished with the DP Dermaceuticals scar. And then normally by about days 5 to 7, that scab will then naturally desquamate off. Don't try and assist the situation with this. The peel itself now updates traditional trichloroacetic acid to give you predictability. So this means it frosts for every patient, every application, every time with just one single application. So there's 35% TCA. You may need to check for local areas what the regulations are for who can use what, particularly for TCA, which is undergoing reviews for the EU. You then have 7% salicylic acid. So this helps the penetration of the TCA to make it more rapid and to make absorption faster. Pyruvic acid is an alpha keto acid that, again, because of its oil solubility, allows for a more rapid penetration. And then using retinaldehyde, caprylol salicylic acid, which is your agent which helps to activate the TCA. There's phenol. This is going to be controversial for some practitioners who will see the ingredient listing and go, hold on, this is a phenol peel, this is a deep peel. No, the phenol needs to be at 30, 60, 70% in order to create that full deep peel. It's blended in with potency oil. With this process though, phenol at 1% serves as an anesthetizing agent. So it helps to make the peel more comfortable. You never apply this peel all over the face. So it's not a particularly uncomfortable procedure. For your applications, you use what's called an Uber stick. The Uber sticks, I found these in Finland. They're actually a dental stick, but as opposed to a toothpick, which is what's normally used to apply TCA, if you get a collection on the end of a toothpick, then you're going to get a drop. And a drop of product is problematic because you need to get it in, not on, not near, not around, but into the area of atrophy. So there is a tiny little sponge on the end of the Uber stick, which means that it holds the product absolutely perfectly. So that sponge means that you have precision for every patient every single time. So with these, we've modified the dental sticks so that they are the right size for your Dermapen procedures, but also the right size to use for atrophic scars, striae, and also wrinkles. So you want only to use the Uber stick. Don't use toothpicks, they're more unreliable, and never gauze this all over the entire face. You will have problems and the recovery will be up to about 2 months. So our process, cleanse the skin. Tri-phase cleanser for the face, microderm exfoliant for the body. Disinfect with your Clinic Prep, don't rub that solution through. Your most common MG collection would be the RAS, but if you want a premium procedure, so you may wish to add an extra 20 or 30 euros on top of the procedure, could be the MG collection HA35 Plus. You're going to Dermapen the area using a combination of glide and imprint techniques. You're then going to remove all treatment residue. As with the Uber Pro yesterday, the reason why you need to do this is because blood has a pH of 7.48. Your MG collection has a pH of anywhere up to 6. Your Uber MB has a pH of 0.8. That's exceptionally low. So if you put 0.8 over the top of blood, it's just going to neutralize itself out. Nothing will work. So use your Clinic Prep to thoroughly clean the skin and make sure the skin is dry. The best part about the caprylol salicylic acid, which frosts predictably and reliably, means that you're not under a time limit. So you're not sitting there with the stopwatch going, trying to treat a full face in a 2-minute time period, worried that you're going to overtreat or worried that peel's going to be left on for too long. As soon as it frosts, job's done. You can't do anything to make it worse, just leave it. So with this, you can treat one half of the face. If it takes you 20 minutes to get every single atrophic mark, not a problem. So by the time you then move on to the other side of the face, once it's frosted, it's completely deactivated. So nothing will build in strength or power. So the frosting generally will occur in around about 30 to 60 seconds. If you are not sure, my suggestion is sometimes step back away from your fluorescent light and look at a distance, and you'll see that the frosting has indeed taken place. No matter how long it takes for you to apply the Uber MD, not a problem, no rush. Don't book this patient in a 15-minute appointment slot, because if you have a patient who looks like this one here, it's going to take a long time to fill all of these holes in. So you don't want to be in a rush because you absolutely need that product physically in, not on, near, or around. Once you've frosted, you're going to have that coagulated effect generally for about 20 minutes, which means even when you put the recover on, you're going to have these little white dots all over your face. So once 20 minutes is over, they should start to tone down a little bit. They will then begin to turn into a scab, dry, tight, itchy, and then that should resolve by day 5 to 7. Following the treatment, cleaner prep will disinfect. You then use your vitamin-rich repair always, followed by your scar cream over the top of the treated areas, and then your cover recover. The patient does not need to wash their face until the next day, but what I recommend is that they always take a bottle of the scar and then reapply every few hours. So this is a product that they will want to put into their handbag, their gym bag, and take with them for comfort application to reduce post-inflammatory hyperpigmentation, but to also allow for an anti-itch and comfortable effect. So we've dermapened the patient's face. A combination of imprint and glide techniques, see the frosting's coming up already. We've then completely removed all residue. As you saw, there was a lot of blood. And now using slow, precise technique with the glue stick, we dip it gently into the area of atrophy, not on, near, or around, but physically into the area. So take your time with this process. If you're going to do fine lines and wrinkles, not a problem. So you would follow the same type of technique, but rather than dip, you would get the patient to look up and then follow through the physical lines, through the wrinkles. So it's going into the area of atrophy, not on, near, or around. So a nice, reliable frosting that's coming through. So you can see exactly where you're going. Don't put a second application on. And this will help you with precision work without over-treating. So take your time with this. It can feel a tiny bit sharp as it goes in, but then it's comfortable. That's because of the phenol, but also because you're not applying all over the full face. This means that you've got a more comfortable procedure for this. Yeah, so I want you to imagine that, say, like a patient, similarly to, say, like botulinum toxin injections, you get the patient to smile really harshly, then you can see the lines and then just follow it through. So then through the nasolabial lines, then the mentolabial folds, so just into the physical line of depth. But you will use a lining technique as opposed to this, which is more like a dot technique. So having a look at some before and afters. This patient here, this is on the cusp of the skin that you've got to be careful. So the patient's of Egyptian background, there is a risk of post-inflammatory hyperpigmentation. My suggestion is bright light for at least 2 weeks prior to treatment as part of your pre-op care with DpD dermaceuticals. This is 3 procedures. What I like about this is that traditionally, if this patient were to come and see you, it's 2001. We've just covered microneedling roller or stamp. We don't have DpD dermaceuticals, we don't have the MG collection, and we don't have the capability for cross-technique combination therapies. Realistically, you'd probably say to this patient, you're going to require maybe 9 or 12 procedures. Now, with Dermapen technology, with DpD dermaceuticals, but also with MG collection and the Uber MD, you can see what we can do in 3 procedures. So this can really speed the process up, creating a mechanical breakdown of the fibrous tissue, but a chemical filling of the tissue. This patient here is the patient that you've seen during the treatments. So after 6 procedures, this is actually the endpoint for this patient. So you can see such a dramatic change, particularly for the ice pick scars. 6 procedures, MG collection RAS, and then MD over the top. But finally, there's a patient also of Egyptian background, but a fairer skin, so less risk for post-inflammatory hyperpigmentation. you can see the response in as little as 3 procedures. So again, we're able to really accelerate. The peels are not expensive to work with. It just requires education. So this is what becomes an ultimate combination therapy of precision, but also expertise as a Dermapen practitioner, understanding how we can enhance the treatments, reduce the overall number of procedures required, but deliver a faster response for the patient. Now we're going to move into drug combination therapies for treatment, particularly of keloids, unstable hypertrophics, but this can also be used for burn contracture scars as well. You will require a drug combination therapy when it's a keloid. This is a non-negotiable. So keloids are not to be treated by a non-medical professional. You can use this as an option for a hypertrophic scar if you wish to speed flattening of the scar up. So it's optional. You may want to use this for certain burn contracture scars in order to try and speed it up. So there's 2 types of drugs that you're going to require. First is a steroid. A steroid prevents hormonal signaling, which will then prevent an inflammatory response, which will then prevent the proliferative response. The proliferative response is where you get new collagen coming through. So if you can physically stop that chemical messaging, that means the mechanics of your Dermapen mechanically uses the needles, I can't be nice about this, to slice through the existing fibrous tissue, but then the steroid will prevent a collagen response following. So you get the benefit of breaking down the existing tissue, but without activating further abnormal tissue. The second thing that you want to do is called an antimitotic. An antimitotic prevents mitosis or cellular differentiation and proliferation. So this means that, again, you can create the mechanical revision, but the combination of steroid to prevent signaling and then the combination of an antimitotic to specifically target fibroblasts to prevent further production and overgrowth at this point means that you can revise a keloid scar efficiently, but guarantee that it's not going to come back and grow worse. The main steroid that is generally agreed universally is called triamcinolone acetonide. The brand names for this is either Kenalog or Kenacort. You can buy it in 10 milligrams, some countries 20 milligrams, then 40 milligrams. It's used in veterinary medicine at 80 milligrams. You will never use this in dermatology. With triamcinolone acetonide, it needs to be an intralesional injection. So it will physically need to be injected directly into the lesion prior to treatment. So it requires a doctor, in this case. I don't believe the nurse will be able to do this for this marker. So the intralesional injection means that you release the steroid directly into the core of the scar. What this will do is prevent your signaling and then promote a regression of the scar. Once you've been needled, you're going to use an antimitotic drug, and the preference is called fluorouracil or 5-FU. The brand name for this is generally Effidex. With this, it is available in an IV form. This is normally reserved for oncology. So as an antimitotic, it's been used for chemotherapy in the past. But the quickest, easiest, fastest, most affordable way to use it is in its cream form called Effidex or 5-FU. So what this will do is help to reduce and help to prevent mitosis, enabling flattening of the scar. If you don't have access to these drugs, which you should for Ireland, you can use imiquimod in place of the 5-FU, or in place of the triamcinolone acetonide, you can use betamethasone or methylprednisolone, but there must be an injection. You can't use a steroid cream. So our process for this is you're going to clean the area, tri-phase cleanser, or alternatively, you're going to use microdermal exfoliant for the body. For your triamcinolone acetonide, It is reactive if you over-inject it. So if you over-inject, it will take you from hypertrophy to atrophy very, very quickly. So triamcinolone acetonide is also very commonly used to remove acne lesions. So if you got to go to the Academy Awards in 2 days' time and you have 5 pimples, you can instantly remove them with triamcinolone acetonide. Good trick. But if you over-inject it, it will then create instant atrophy and you'll end up with holes in the skin that will look like metadermic marks. So for this, you have the options of 10 milligrams and 40 milligrams. So we can log or we can record. So the options, 10 milligrams or 40 milligrams. Some countries do have 20. With this, the larger the area, you want 10 milligrams. So if you have a large scar and you use a high dosage and concentration over a large area, then your risk of creating atrophy is going to be substantially increased. So for larger areas, that's a very, very large scar. For large area, 10 milligrams. You want roughly 0.03 to 0.05 milliliters per injection point. So using an insulin syringe or a botulinum toxin syringe, you're basically looking at 3 to 5 units per injection point. If your scar, however, is small, then you can afford to up the dosage. So you can use 40 milligrams, and again, the same dosage, 0.03 to 0.05 milliliters per injection point. So just be conscious that you do not over-inject. Also with this, you cannot use the injections more frequently than every 6 weeks. Otherwise, you will go into atrophy mode. So whether you're using Dermapen or not, no frequently than every 6 weeks. So the protocols for this, you want to administer pre-op intralesional. That's a very vague term, but it means that you need to feel that the needle is in the physical core or center of the scar. So it's not superficial, it's not deep, it's into the core itself. If your scar is large, you're going to use 10 milligrams. If your scar is smaller and precision work, less injections, use 40. You then want 0.03 to 0.05 milliliters per injection point. So that's not total. All these 1, 2, 3, 4, 5, 6, 7, 8, 9 are not 0.05 divided by 9. This is 0.03 to 0.05 per injection point. How do I know if I did good? If you massage the area, just simply rub it gently, it will turn white. So if you massage here and this side has not turned white, it doesn't show any blanching, then you're going to need to put more steroid in because otherwise it's not going to work. So once you massage that through, and this will be on any skin color, from white to dark, it'll take up a whitish tone. You then want to wait 2 to 20 minutes. I tend to wait more towards 2, 3, a few minutes with that, rather than waiting the full 20 minutes. Once you've done this, you're going to use your Dermapen, probably using imprint technique. Still use your Mesoglide. I suggest the MG collection RAS. And you will now treat the full areas that have been prepared with the triamcinolone acetonide. Following this process, you're then going to remove all your treatment residue. Make sure the skin is dry. The fluorosil comes in a large tube. I'll bring this out at break. And the fluorouracil is just like a white cream. So you want around about half to 1 rice grain of product, and then you're going to simply massage that in over the top. So post-op, we're going to try and avoid mask. We're going to try and avoid vitamin-rich repair. We're going to try and avoid scar. We're going to try and avoid cover-recover. Try and avoid your other DpD dermaceuticals. The fluorouracil does not come home with the patient. So this remains in clinic. The reason why I say this is fluorouracil is typically prescribed for treatment of actinic and solar keratosis. So if you have ever seen generally an older guy walking down the street, he looks a little sporty and he's got all of these big black scabs all on his face and all up his arms, he's on fluorouracil. So it's treatment to remove pre-skin cancers or actinic or solar keratosis. So this is a unique way to use the anti-mitotic drug. In that case, the patient would take it home and use it every single day, twice a day for 2 weeks. But in this case, the fluorouracil remains in practice. The patient does not take any of the products home. So the fluorouracil you want to leave on for at least 8 hours. Following that 8 hours, you can then apply your vitamin-rich repair, your scar cream, and some DpD dermaceuticals cover-recover. Your doctors will say to you, well, hold on, fluorouracil is extremely phototoxic. It's extremely reactive to light. That's the reason why you get all these big brown scabs all on the face. Yes, it is when you use it at home twice a day, every day for 2 weeks. But when you're just applying it once in clinic, and you're only doing this protocol once every 6 to every 8 weeks, the patient can leave it on without wearing sunscreen for at least 8 hours. So this is a C-section scar. This is the injection of triamcinolone acetonide. It's 10 milligrams in this case because of the length of the scar. So you can see just a small amount per injection point. You can also see where there's a bit of resistance as the needle goes in. So you feel that resistance, then the needle goes through further, so you know that you're physically into the core of the scar. The triamcinolone acetonide can be comfortable for some patients, but if you're doing localized scars, the physical pressure, because you're putting liquid into a scar and expanding it, can sometimes feel uncomfortable for the patient. After we've massaged the area, this is MG collection applied onto the skin, and we're going to use a combination of both glide and also imprint technique. So we've waited the appropriate 2 to 20 minutes. This is imprint technique first. It'll soften up the scar. Our aim is to create pinpoint to moderate blood. The reason why more pinpoint is you can see that this has still got some redness within it. So this is also distributing the steroid within the skin. And now we go in with some glide technique over the top. So particularly following the imprint, you see that the imprint technique is really softened up the scar. So is the steroid, so it's more pliable. So then as you glide over the top, you can achieve your visual endpoint significantly easier. This is the fluorouracil. So in this case, just because of the size of the scar, you can just apply around about a rice grain. Just apply it onto the area. It feels just like moisturizer. With this, the fluorouracil, particularly if you're doing multiple treatments, it also serves as our advanced dermatology protocols for treatment of vitiligo. There's a very unusual response or consequence with fluorouracil that it can stimulate melanocytes. So in some cases, patients may find that there's a little bit of darkness, as you can see following removal of this keloid here, that should resolve around about 2 months following treatment. So here's our success stories. Triamcinolone acetonide, 40 milligrams, Fitzpatrick 6 skin. Dermapen, imprint technique, and then the 5FU. This is a true keloid. This is a hypertrophic scar following surgery. This is after 4 treatments, but you can see that the patient obviously is going to require more procedures. Sorry, I'm actually light on that one. This is 1 treatment, but the patient's going to require a 2nd treatment. To explain the story here, the patient was 15 years old at the time the photos were taken. This is a typical burn contracture scar that's quite common for the South African market, where someone in a township has rolled into a fire as a child. In this case, the scarring was so severe that the patient couldn't actually move. So it was affecting mobility. So it's not just skin, it's muscle, ligaments, and tendons as well. The patient went to see a plastic surgeon who was a microneedling specialist. There were 21 sessions of 3 to 4 millimeter rollers. So these were performed under full general anesthetic in this case. But the results weren't coming through. So we had a chat and said, why not try the technique of steroid, the technique of Dermapen, imprint technique as well as glide, and the technique with the Ferrocell. The results were unbelievably impressive, with the surgeon saying the last 2 sessions were life-changing. So what couldn't be achieved in 21 sessions with traditional rolling, what could be done with the 3-in-1 were incredible for this patient. I also want to show here that even without drug combination therapy, that Dermapen can work for burn contracture scars on 2 levels here. So this patient here is a burn contracture. This is just Dermapen. So there's no drug combination therapies, and this is with our highly active hyaluronic acid. 2 areas I want you to notice that you can see the burn contracture scar has reduced and improved after 2 procedures. But I also want to show here that even after 2 procedures, you'll notice that the color is beginning to return. So not just only do you see success with scar revision, but you also see success with melanocyte growth factor. This type of effect was first observed by a Canadian practitioner who used to use cosmetic tattooing to try and repigment scars. What he noticed was the needles, even when there wasn't pigment, was still activating melanocyte balance. So I want to show that the versatility of microneedling with Dermapen, even as monotherapy, can be incredibly effective for this type of procedure. So let's talk home care. Your 2 non-negotiables. Number 1 is scar. That must be part of your combination therapy. If your patient is not willing to use this, it's going to compromise your responses. So 7 types of reepithelializing silicone, zinc, beeswax, and for post-inflammatory hyperpigmentation, safflower seed oil hyaluronic esters. Apply liberally as often as you want. It's like the lip balm of treatments. When you feel you need it, apply it. Your second non-negotiable is the retinol active. So with this 0.05% retinaldehyde to promote regulated collagen modulation, copper peptides, high diffuse hyaluronic acid. So I would apply this first. You can do this twice a day, once a day, and then apply your scar over the top, but apply your scar liberally. If you're dealing with a post-inflammatory hyperpigmented scar, use the bright light during the day. So bright light in the morning with scar over the top, then at nighttime, retinol active with scar over the top. And of course, for any signs of post-inflammatory hyperpigmentation, sunscreen is incredibly important. So using the Cover Recover frequently in tandem with the bright light to reduce any darkness associated with the scar. That concludes the Scar Master topic. For your option, we're running about half an hour early. I can either cover the mesotox and the PRP topic now, and then we can take a break, or you can take a break now, and then we go into this topic afterwards. What's your preference?
You can have a cup of tea now.
Yeah, no problem.
Just for a second.
Just put the video on pause. This is excerpts of the Acne Masterclass, and the Acne Masterclass initially goes for a full day. This one is my most personal, passionate masterclass. As a teenager, I was on isotretinoin 4 times and was left with such horrific consequences to my liver, to infections in every finger and every toe, and still no success for my acne until well into my late 30s. And so I really wanted to put passion into this class to create something that was very realistic, something which really counterbalanced a lot of the misinformation that we see out there on the market, but to have a very honest approach to the acne topic, to give hope, but to also give a realistic approach, and then to combine this in synergistically, of course, with Dermapen World and with DpD Dermaceuticals. I want to begin with definitions. If you ask your average teenager what pus is, they're going to tell you that pus equals dirt and infection. So the more pus, the more oil, then the dirtier and more infected you actually are. No. Pus is white blood cells or macrophages, phagocytic cells, that have successfully achieved the mission of phagocytosis. So your endpoint of this is phagocytosis absorbs the pathogens, and then your endpoint is going to be pus. So although socially someone with a very pussy face is probably going to look worse than someone with a very inflamed, angry face, such as papules or such as nodules, the reality is the more pus you see, the better their natural immune system is to try and treat and target the acne phenomenon. Acne, by sheer definition and technical definition, is infection plus inflammation and a level of congestion and clogging. So I look at comedones, open and closed, blackheads and whiteheads, which is otherwise known as comedonal acne. These don't entirely reach the full definitions because there's no inflammation. When you touch them, they don't hurt, but there's also no infection with these. So definition-wise, a blackhead is where you have oxidation of a collection of sebum, dead skin cells that are sitting within the skin. So my very bad drawing of a follicle here, you essentially have this little plug that's sitting here. But what's different, why there's no infection and inflammation, is because oxygen is surrounding through here. As the oxygen continues to surround, it then creates oxidation, which then turns that blackish color. You'll notice that that color is only dark up the top where the key oxidation is. It's not down the bottom where you'll find that it's a very waxy collection. Where it sits just a little bit more superficially under the skin, but again, there's no inflammation or infection, this is where you're going to see a white head. I'm going to refer to another term later on, which is called acne cosmetica, where you've got the direct correlation between comedogenic, so something that clogs and congests, which then will contribute to this type of closed comedone called a whitehead. But again, when you touch these, there's no pain, there's no inflammation. Once you then completely seal off the follicle, this now means that you can harbor Cutibacterium acnes, which lives in the sebaceous gland, now within the follicle. As part of this infestation of infection, this now creates inflammation. So depending on your level of inflammation, this puts pressure upwards, sideways, also downwards as well. Your first level of inflammation and infection is a papule. When that has a resolution due to phagocytosis, your papule will become a pustule. So this pus is actually a good sign. When your papule is now affected with further infection, inflammation, clogging and congestion, then your papule will become a nodule. A nodule is an unresolved papule that's deeper and larger in size. But when you have phagocytosis in the presence of pus, it then becomes a pustule. So a pustule then becomes a cyst. So we see here, open, close, comedones, no infection, no inflammation. Papule, nodule, unresolved inflammation and infection. But when there's resolution through phagocytosis, you then have a pustule and a cyst. So your nodule is more severe than a papule, and your cyst is more severe than a pustule. Seborrhea is the genetic predisposition to have an oilier skin. But I want to be very clear, just because you have an oily skin does not necessarily mean that you're going to have acne. Acne, by sheer definition, is an imbalance of over-thickened sebum, which then leads into retention hyperkeratosis, which is clogging or congestion, which then leads into infection and inflammation. Let's talk about what can be treated with Dermapen 4, but also looking at new definitions. So, two areas of acne that I'm not going to class as traditional is called acne cosmetica, which I mentioned before, and acne mechanica, which is the term that we use for maskne. The reason why is because by definition again, all acne is hormonal. So with this, if your acne cosmetica, your trigger and your activator is in fact comedogenic ingredients, your trigger's product, it's not hormone. Likewise with acne mechanica, it's friction and it's a combination of bacterium that's causing this. So again, it's not hormone, but for all other forms of traditional acne here, all acne is hormonal. So we understand that as our trigger and activator. Acne vulgaris translates as generalized acne. So you have a combination of open and closed comedones, blackheads, whiteheads, but also papules and pustules. Comedonal acne, I'm going to be controversial and say this is not technically acne, because you don't have infection, you don't have inflammation, but a combination of open and closed comedones. Papulopustular acne is stage 2. So you have a combination, like acne vulgaris, of open and closed comedones, papules, pustules. Nodular cystic acne is acne stage 3. So you have a combination of open and closed comedones, papules, pustules, nodules, and cysts. You can treat acne stage 1, you can treat acne stage 2, you can treat acne stage 3, but I do not recommend that you treat acne stage 4, which is acne fulminans or acne convolata, that is active acne on the back there, with Dermapen. Irrelevant whether you're an aesthetic or whether you are a medical practitioner. At acne stage 4, you will require drug combination therapy. What's really the difference between something such as nodular cystic acne versus acne fulminans? Because acne fulminans is still technically a form of nodules and cysts. When you look at this nodular cystic acne here, despite the fact that the drawing's a little bit hazy, you can count individual lesions. With this one, it's a little bit harder. There's 1, there's 2, 3, maybe there's 3 in this or 4. This looks like there's 2 in 1, 3 in 1. So what actually happens is when you have multiple follicles, they all have retention hyperkeratosis, clogging and congestion. The pressure can't go up because it's sealed up top. So the pressure then tries to go sideways. But the problem is when you have the follicles all close to each other, they begin touching each other. So where's your pressure going to go? It's going to go down. So when it goes down and you have connectivity and trenching between the follicles, that's what constitutes acne stage 4. So that's what defines acne fulminans or convolata, and this is where you will need medical intervention. Someone mentioned to me last night as a very old-fashioned term, acne rosacea. Rosacea has nothing to do with acne. As we went through yesterday, just a very, very small snapshot of the rosacea condition, it's got nothing to do with hormones. It's got nothing to do with traditional sebum conversion. So the term for acne rosacea since the 1980s has been called papulopustular or stage 2 rosacea. So although you have papulopustular rosacea, papulopustular acne, these have nothing to do with each other. As I identified yesterday, we've had a change of dosage for isotretinoin oral medication, Dermapen or isotretinoin. So with this, traditionally, if the patient is on 30 milligrams plus a day, you don't treat. But if a patient is on 30 milligrams or less a day, you can treat if the patient is on an oral isotretinoin. It's not a problem if your patient is on prescription topical tretinoin or adapalene or vitamin A creams. They can use these right up to the day of treatment, no problem. They will need to wait 4 to 5 days before applying, so use your standard post-op products. If the patient's on other antibiotics, so it could be a topical erythromycin, if they are on a systemic doxycycline, note that sometimes this can make the skin a little bit thinner, which means that they will bleed easier and they will also be more photosensitive. They still need to wear cover recover. So there's absolutely nothing that suggests that cover recover will clog, congest, and make your acne worse. So you can still treat, you just need to be conscious. Having a look at breaking some myths, I want to talk about the sebum phenomenon here. Sebum has an extremely bad reputation, and we're told that you need to remove it. And as such, if you have too much of an oily skin, then you're going to get acne and you're officially dirty. What fascinates me with this phenomenon is that it's imprinted in your mind from childhood. So I remember being bathed as a baby, young child, whatever. And I remember that when I'm washed, that I need to hear that squeaky clean sound. I remember also when I'm taught how to clean dishes, that it needs to be. And when glass cleaner. So we're taught that that squeaky clean sensation equals clean, and cleanliness is next to godliness. And so this starts this process very, very young, where we believe that sebum is bad. So this is my interpretation again of follicle. You have your sebaceous gland. Inside your sebaceous gland is a specific cell called a sebocyte. The sebocyte is responsible for production of sebum. As I covered yesterday, sebum is a composition of 57% triglycerides. That's base oil. So olive oil is a triglyceride. There's 25% wax esters. So a wax is still a lipid. It's just not chemically a base oil. You have 15% squalane, so another lipid. And then you have 2% cholesterol esters and 1% cholesterol. So it's a very, very exact recipe. And we're going to explore later on why this recipe is so exact and the role of P. acnes or Cutibacterium acnes and how that influences sebum quality. With this, the sebum is then produced by the sebocyte, my bad drawing, which then makes its way to the mouth of the sebaceous gland. It then releases the sebum, which then travels up the hair and is distributed onto the skin. With this process, also take into account that you have in granulosum within the epidermis, this is not to scale, you have what's called a lamellar granule. And these produce free fatty acids plus ceramides. Your sebaceous gland also produces vitamin E. So the combination of vitamin E plus sebum, 57% triglycerides, 25% wax esters, 15% squalane, 2% cholesterol esters, 1% cholesterol, coming through here, and then the release of free fatty acids and ceramides from lamellar granules, then join together and create the lipid aspect of your skin's barrier function. All of this is regulated by hormones. So this is also determined by your genetic predisposition. So it is impossible, despite what the rumors say, that if you over-cleanse your skin goes, uh-oh, I haven't got any sebum or barrier function, I'm going to produce 3 times as much. Your skin's not that smart. So it produces its genetic amount based on hormones. What can make you oilier? Parkinson's disease and puberty. That's it. So when you look at all the interviews with Muhammad Ali, when you look at current interviews with, say, Michael J. Fox, all or both with Parkinson's disease, you'll notice that there's a more waxier appearance to the skin. As some part of this condition, it increases sebocyte production and then subsequently increases sebum production as well. Having pizza for dinner is not going to make an increased sebum production. There are links to insulin resistance or a high glycemic index diet over a long period of time, which will affect insulin, your pancreas, and in turn can affect your adrenal glands and production of hormones. But there's no direct correlation that a hamburger is something going to get your skin producing more sebum. With this process, because we're taught as children that sebum is bad and you've got to make it squeaky clean, we're taught that you physically need to remove it. This is immensely problematic. We're also taught that the pH of human skin is all 5.5 for everyone. That's not true. The range is between 4.5 and 6.5. What's interesting is that generally a Fitzpatrick 1 and 2 sits more acidically. So around about 4.5. That's the reason why you will see more vascular, thin, acidic issues on a Fitzpatrick 1 to 2 skin. Fitzpatrick 3 to 4 tends to sit around about 5.5, and then a Fitzpatrick 5 to 6 will sit a little bit higher at 6.5 in this case. When we look at acne patients, when they're told that they're bad and their skin is dirty and they must cleanse, then they fall into this trap of overstripping and over-cleansing their skin. This is the worst thing that you can possibly do. So to explain this process, it's called pH logarithms. Just for ease of mathematics, let's say the pH of the skin is 5.5. So I'm going to be your best acne patient ever, and I'm going to completely remove that bad sebum because I know that it's giving me acne, and this is what I'm told, this is what I'm taught. So with this, I am going to use a drying foaming cleanser. So that might be sitting at a pH of maybe 8.5. I then buy from the supermarket an acne clearing foaming cleanser, pH roughly 9.5. I then use a basic bar soap, or I can then use one of the world's leading selling acne reducing bar soaps, which is sitting at an extremely alkaline 11.5. So you look at this process here and go, okay, when I am at 5.5 and I strip my skin with 11.5, it's only 1, 2, 3, 4, 5, 6 steps away. Not a problem. I'm then going to use my toner, which will then re-acidify my skin. I'm back to normal, and then I've got clean skin and a great start. Not at all. What happens is a pH logarithm. So the difference between 5.5 and 6.5 is not 1, it's 10. The difference between 5.5 and 11.5 is actually 1 million steps away. So you can see that this logarithm aspect here, that the farther you get away from your skin's acidic environment, and put it into an alkaline environment, number one, when you put it into an alkaline environment, this is going to encourage bacterial proliferation. Skin needs to be acidic. Make it alkaline, it will become more infected. Likewise, also when you create an alkaline environment, not only does it strip, but it dehydrates the skin. When you dehydrate the skin, you're going to deactivate your natural process of keratinization and exfoliation. So cleansing will actually make your skin more clogged and congested. Likewise, also with this process here, particularly once you start getting up to 11.5, it will take your body up to 8 hours to produce its own sebum to then try and reacidify itself. So this concept of putting toner on the skin to reacidify does not work. What reacidifies is the entire process of your sebaceous gland, sebocyte production, now creating sebum. If this takes 8 hours after you using products at 11.5 pH, which is very common for acne cleansing products for that squeaky clean sensation, you clean your face in the morning, you go to the gym, clean your face, then clean your face before you go to bed. That's 24 hours of your acid mantle becoming an alkaline mantle. And that 24 hours every single day is a huge issue that's contributing to your acne. This is why the pH of the Clear Foam cleanser is 7.2. So 7.2 is enough to remove excess, but at 7.2, it's less than 100 steps away, which means that for an oilier skin, it will resolve in around about half an hour to rebalance. So this process is designed to remove excess, but to still leave the necessity, still leave the barrier function physically there. Looking at acne formation, there's 3 triggers and activators, and unless you target all 3 at once, you will never have a long-lasting response. So we commonly see that a patient will go into antibiotics. They see success for 6 months, for 8 months, then it all comes back. They will buy something off the television, which has an antibacterializing agent. It's great. It will work for 3 months, then they're back to square one. They will then undergo aesthetic treatments, chemical peels, microdermabrasion. It works, but then it all goes back. You need to target all 3 aspects at the same time. If you don't, you won't achieve any longevity. It's not sebum itself that's the problem. It's the conversion of sebum into a thicker consistency. So this thickening is the issue, not sebum itself. This then leads into what's called retention hyperkeratosis, which is clogging and congestion. And then this leads into bacterial proliferation, which in turn creates inflammation and further infection. To draw this process up, the big boss of all hormonal production in the body is the pituitary gland. The pituitary gland is the boss of your thyroid, but it's also the boss of your adrenal glands. It's the boss also of your pancreas. It's the boss of all hormone-producing glands. So from pituitary gland, we have a direct correlation down to the adrenals. Adrenal means above the kidney. So the adrenal glands sit above the kidneys. Your left one is more circular in shape. Your right one is a little bit more triangular in shape. Due to that, generally you should find that your right-hand side has worse pain tolerance than what your left-hand side has. Also, because adrenals are responsible for production of androgen or male hormones, this is a key reason as to why guys have worse pain tolerance than what females have. During puberty, what we're going to have is a hormonal message. And that hormonal message will come from the pituitary gland, and then it will send message to the adrenals. And what we get is hormonal production and signaling of androgen hormones. So the word androgen sounds very, very scary. but androgen is just the easy way of saying your male hormones. With this process here, there's two key androgen hormones that I want to focus on. The first one, of course, is testosterone, and the other one is called androstenediol 317. With the release of testosterone, which is a steroid hormone, so that's just its category. So again, don't be scared of the word androgen, don't be scared of the word steroid hormone, because we're going to put negative associations on these. First off, the testosterone is going to determine enlargement of the sebaceous gland. So when you look at a child, say 5 years old, 6 years old, 10 years old, they have perfect skin. And the reason why is because their follicle has a very, very small little sebaceous gland that sits there. During puberty, though, when you get messaging from the pituitary gland to the adrenals, one of the first things it does through the release of testosterone is now creates enlargement of the sebaceous gland here. So if you have a large surge of testosterone as part of your genetic predisposition, you will produce a larger sebaceous gland. That's a joke. When you have a larger sebaceous gland, it's going to hold more sebocytes, which means that you're going to produce more sebum. Congratulations, you're a oily-skinned person. If you have a smaller release as part of your genetic predisposition of testosterone, then you're going to produce a smaller sebaceous gland, which means that you can't hold as many sebocytes, which means you are a dry skin person. What now happens is we have testosterone, which now determines the size of your sebaceous gland. But then the combination of testosterone and androstenediol 317 will then work together to determine production of sebum based on your sebocyte potential in your sebaceous gland. So, big surge of testosterone, bigger sebaceous gland, holds more sebocytes for your skin person. Smaller release of testosterone, your genetic predisposition, smaller sebaceous gland, smaller amount of sebocytes, smaller sebum production. Now the two of these together, androstenediol 317 and testosterone, are going to join together for the sebocytes, then for production of sebum. The sebum is then produced. This is not a very correct anatomy, but with this we then get release of the sebum onto the skin's surface. In this case, under normal circumstances, the sebum would be the consistency of water. That's a problem because if you're trying to create barrier function, it's going to evaporate. So this isn't good enough. What the body is then going to do is send a message from the adrenals, which will then go to the testicles, so the testes for guys, and then to the ovaries for females. And what this does is creates a conversion. So you go from a steroid hormone, such as testosterone and androstenediol 317, into production of an anabolic steroid hormone. In this case, it's called dihydrotestosterone, or DHT. Or testosterone 5. The dihydrotestosterone, or DHT, is roughly 10 times more powerful than the testosterone and androstenediol 317. And as part of this messaging and conversion between the adrenals to the testes or to the ovaries, it then thickens up sebum consistency to say the consistency of olive oil. This is perfect. That's everything you want in sebum. So that means if I put a layer of olive oil on my skin, it won't clog, congest me. but it's enough to waterproof the skin. That's everything you want. Roughly for most patients, this conversion process of steroid hormone into anabolic steroid hormone is a conversion rate of around about 17%. However, once you start having, wrong figure, is around about 10%, my apologies. Once you start having an over conversion, however, so 10% of this conversion rate here turns into 11, 12, 13, 14, 15, 16, 17. This then influences the consistency of the sebum to take it from water, which is bad. That's why you want this conversion at roughly 10%, 10 times more powerful, to then give you the consistency of, say, olive oil, which is good because it will waterproof the skin, will not clog or congest, but now you're going to turn it into the consistency of room temperature butter. So if you over-convert this 10% to around about 17% up to, then you change the conversion and thickness of the sebum. And once it's at a room temperature butter consistency, that means it's so thick and clogged and congest that it's going to be very difficult to leave the sebaceous gland. It gets stuck within the follicle and it's unable to easily be released onto the skin's surface. So I want to show you that it's not sebum itself that's bad. It's your over-conversion here that's talking to itself that now creates problems. When you have this over-conversion, there's a whole host of other issues that are going to take account. So with this, we need to look at what physically is now managing this conversion process. What manages the conversion into 10% is a specialized enzyme that is called 5-alpha reductase. So you can see this up here. 5-alpha reductase is important because it also links into things such as Dermapen baldness. So it regulates this process here, this 5-alpha reductase. If your 5-alpha reductase is not working sufficiently, which means it's unable to regulate this process here, you need to go another step further to find out, well, what's regulating my regulator. And what regulates the 5-alpha reductase within the body is zinc. So if there's a zinc deficiency, which is extremely common in acne patients, particularly hormonal teenage boys, every time a younger male ejaculates, on purpose or not, they lose their entire recommended daily intake of zinc in one shot, sometimes 2 or 3. So with this process here, I want to show that zinc is difficult, particularly for younger males, to generally hold within their system. So if zinc is what regulates the 5-alpha reductase, then in turn, you need to look at the role of systemic zinc for conversion, but also for the role of regulating your regulator. So if you balance your 5-alpha reductase, you then balance your conversion of the testosterone into the dehydrotestosterone, testosterone 5, or DHT. So this is a drug-free way that you can treat. Based on the advice of dietitians, the recommended daily intake of zinc RDI is 23 milligrams. But it is safe to zinc 1 milligram per kilogram during this time period. So you may have patients taking up to 50 milligrams, 60, 70 milligrams of zinc during this time period, just to achieve some level of balance. Other areas which can over-convert this, particularly, is what you see is phenothiazidine, which is an ingredient found in antihistamine, but also in antipsychotic medications. Note that antipsychotic medications also often double up as epilepsy medications as well. So if the patient is taking a lot of antihistamines, if the patient's on antidepressants, if the patient experiences epilepsy, this can contribute to an imbalance of 5 alpha reductase and then an overconversion coming through this process here. So I want to show through this process here that overconversion interface has nothing to do with sebum consistency. What I also want to show here is that it's not a dirty issue. It's a hormonal issue, but really it's not the sebum itself that's the problem. It's the overconversion that becomes the problem. Just to divert very, very quickly, when you look at other methods of overconversion, I think of someone I used to go to the gym with absolutely years and years ago, my height, my build. Do you think if I work really hard, I'm going to turn into a 120 kilogram muscle man in about a year's time? No, I haven't got the body shape for it, but he's managed to do it. But with that process of anabolic steroids, which is what dihydrotestosterone is, rather than having it produced by his balls, I didn't say that. What he's doing is getting it out of a syringe and then injecting that into his butt. So there's a couple of problems that happen with this. When you're overconverting and overexposed to the anabolic steroid from a syringe, you're going to notice that this overconversion rate here, particularly with the testosterone, means not only do you have enlargement of the follicle and the sebaceous gland on your face, but it also enlarges the follicle and sebaceous gland on your chest and your back. Larger follicle, larger sebaceous gland, more sebum, higher risk of acne. What also happens is when you have a follicle that's larger in size and you then have a surge of more androgen hormones, that means larger follicle can also equal thicker hair. So you find that you end up with acne across the chest and the back. You find that you end up with thicker terminal hair growth on the body, but due to the 5-alpha reductase and the sensitivity to this, you actually then end up losing capillary hair on your head. What you also find is due to the conversation that your adrenals will have from the testes, from the steroid, then to your thyroid or pituitary gland, you'll find that there's a change of weight distribution. So for guys, it's typically a triangle that looks like this. And then for females, if you take into account polycystic ovarian syndrome, hirsutism, or where there's an androgen imbalance, they will take the effect of a triangle, which looks like this. So the bulk of the weight will happen through here. Guys, the bulk of the weight will happen through here. But also consider that if your steroids are coming from a syringe, as opposed to these guys, then these guys kind of are out of a job. So you get testicular shrinkage, and then that can also lead to sterility as well. So this is our first area here of sebum production. The issue is not the sebum itself, the issue is this overconversion. The overconversion is managed by the 5-alpha reductase. You can manage that through zinc supplementation, or that can be managed from a doctor who can then reassess if there's a hormonal imbalance. The next area I want to have a look at is, okay, if I write this off the board, is called retention hyperkeratosis. And this one is, again, a huge area where there is a lot of misinformation. I drew this up yesterday. I have an ad in French television, which I find exceptionally funny. It's a bunch of very, very attractive children, as you can sound right, but very good-looking teenagers having a wonderful day on dad's yacht or something, with perfectly clear skin, and they're all happy and laughing. And the reason why life is so good is because they've used this pimple cream. And so what happens is they have a follicle here, and they used to be dirty. So they used to have dirt, clogging, and congestion here. And then they've used this miracle brand new zip cream, which is then exfoliated down the bottom here and removed all that clogging and congestion up and out. This drawing is what your average teenager thinks their ziti skin looks like. Wrong. So if I were to draw that up closely, this is your epidermis, this is your dermis, this is your hypodermis. So this is where you have the follicular bulb and the hair, and where you have blood vessels coming through. So we understand that the clogging and congestion is not from the bottom up. The clogging and the congestion is actually from the top down. into the skin. So the second trigger that we take into account is called attention hyperkeratosis, which is clogging and congestion. For clogging and congestion, we need to have a look at what naturally promotes exfoliation of your skin to remove buildup, to remove clogging and congestion and damage within the skin. So I'm going to draw a really, really large follicle here. First thing for the epidermis here. What's going to manage your first intervention point of clogging and congestion is going to be the role of epidermal growth factor, but also keratinocyte growth factor. Both these growth factors are activated through your dermapen. So epidermal growth factor is the big boss of all processes here within the epidermis. So this is your dermis. This is your hypodermis. This is a very liberal interpretation. But what manages this aspect here of functionality for the epidermis, for normalization, for communication, for regulation, is balanced through epidermal growth factor and keratinocyte growth factor. So if we have here basal, spinosum, granulosum, I'm going to skip out the cilium and corneum. Basal layer is where you have your keratinocytes, and your keratinocyte undergoes a process of keratinization, which then is sloughed off as a corneocyte. What signals to the keratinocytes found in basal epidermis here initially is epidermal growth factor and keratinocyte growth factor to now encourage the process of keratinize, 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 keratinize. So this is point number 1. Intervention point number 2 for keratinization here occurs in granulosum. What you find in granulosum here, I've referred to these before, are lamellar granules. The other word for this is called a keratinosome. Different to a keratinocyte, but a keratinосome. That's up there. So a lamellar granule, in addition to producing ceramides and free fatty acids, which we discussed before, lamellar granules also produce enzymes. So these include proteinases, phosphatases, glucoside hydrolases, and corneodesmosonin. So all of these enzymes here that you see are also produced by the lamellar granule. So this becomes second step. So we know, particularly from an aesthetic perspective, if you want exfoliation, you could use an enzyme, you could use a mechanical scrub, you could use a chemical alpha hydroxy acid. So enzymes can also create this level of exfoliation. So we now have a process of intervention. We start exfoliating up. Intervention number 1 is basal, epidermal growth factor, keratinocyte factor. Intervention number 2 is lamellar granules, which release glucoside hydrolases, phosphatases, proteinases, and corneodesmosomins. At this point, I'm going to ask you a question. And this one's interesting because normally the doctors never get this one right. If you're performing, think back to basic beauty therapy, and you have an enzyme mask or an enzyme exfoliant, what's the one thing that you need to add to it to make it work? Exactly. If you strip your skin with a pH of 11.5, a pH of 8.5 and higher, and you strip your barrier function away, you dehydrate the skin. So when you dehydrate the skin, you have no water. So this means that the enzymes produced by your lamellar granules now cannot send any messaging because they're completely dehydrated. So what happens now is the message of keratinization begins to exfoliate, 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 point number 1, but now at point number 2, because it's a red light that never turns green, you're going to start ending up with build-up here. because you deactivated these enzymes. The third aspect of intervention here is in stratum corneum. And these are called stratum corneum chymotryptic enzymes, or SCCEs. And these are also specifically called KLK 5, 7, and 14. I mentioned these yesterday for rosacea. KLK stands for kallikrein-related kinase enzymes. So, the traditional beauty therapy, you're always told that the stratum corneum is dead. It's very, very alive. So, with stratum corneum chymotryptic enzymes, so enzyme is going to activate a process of exfoliation. The enzymes by name are called KLK 5, 7, and 14. These will also then say, slough off. Again, if the skin is dehydrated, if it's stripped and dry because of its alkaline environment, because of over-cleansing, putting toothpaste on your face, putting clay mask is the worst thing you can put on your face, putting carbon mask is the worst thing, charcoal, to put on your face. Anything that strips that barrier function is going to make your acne worse. So what happens is that this process of keratinization is still saying keratinize, 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 keratinize. It stops at point 2 because the lamella granules are dehydrated, but down here doesn't know that, so it still keeps pushing up. So eventually it pushes up further and further, but nothing sloughs off because your stratum corneum enzymes can't exfoliate this off either. So what you now end up with is all of this thickened sebum, dead skin cells, the debris, whatever that's going to be, which traditionally epidermal growth factor and keratinocyte growth factor would begin keratinization, which would then become pushed up and out through the enzymes in your lamella granules, which would then be sloughed off and removed from the enzymes of stratum corneum chymotryptic enzyme. Now it will get stuck. And so you end up with this clogging and congestion, not from the bottom up, like on the television, but actually from the top down, which looks like this. So once you start closing this down, you now create this plug over the top of the skin, and this is what characterizes retention hyperkeratosis. So clogging and congestion is actually a little bit different to what your average teenager thinks about. So if you've got impaired barrier function or rosacea skin, this is why papulopustular rosacea can often happen. There's no barrier function. If you have genetics, so genetically you're a very, very dry skin, that can also lead to different lumps and bumps on the skin as well. So we understand that you need to step in at this point. There's no product that you're going to apply onto your skin topically that's going to miraculously handle your sebum conversion. So this is where you may need a doctor to step in, or a first step could be something like zinc. So you'll notice that I'm not saying you need a cleanser straight away, you need pimple cream straight away. You actually need zinc straight away. Then for the second step, you need to stop dehydrating your skin. Throw out the cleanser, which gives you squeaky clean sensation. Never put toothpaste on your face, never use clay mask on your face, never use a pore strip on your face, never use a charcoal mask or anything. If it feels tight and you're running for a jar of moisturizer for relief, this is not the right product for you. So with this process here, first off, if you need a very superficial exfoliation through here, try the microderm exfoliant. It's micronized bamboo particles plus 5% lactic acid to give you a superficial release of any superficial clogging and congestion. But if you have deactivated stratum corneum chymotryptic enzymes and deactivated corneodesicinones, proteinases, phosphatases, and glucoside hydrolases from your lamella granules, then you need hydration. Stop stripping the skin. So you could get both exfoliation and hydration from the DP Dermaceuticals Clear Lotion, 2% salicylic acid to dissolve this, but a base of Manuka honey and a base also of hyaluronic acid to reactivate this process. If you then need to go the next step further, during your treatments, use the Uber Pro. So you could actually use your DpD Dermaceuticals, not clearer lotion, but you actually use the clearer MG collection, which is 2.5% pyruvic acid, and then use your Uber Pro. You have this perfect synergistic effect here that targets point 1, 2, and 3 to give you a reduction of retention hyperkeratosis. The final step that you have is once you have this bacteria here, once you have this clogging and congestion, this now leads into bacteria. Is that okay if I wipe some of this off? Okay, so I'm going to draw in my interpretation of the sebaceous gland. Just work with me on this. Your sebaceous gland has sebocytes, and sebocytes produce sebum. Sebum is 57% triglycerides, 25% wax esters, 15% squalane, 2% cholesterol esters, and 1% cholesterol. Sebum is ingenious. The triglycerides is not 58%, it's not 56%, it's 57%. Also, under normal circumstances, if you add water and oil together, they don't mix. But when you look at your skin's barrier function, it's a water in oil emulsion. So the 2% cholesterol esters and the 1% cholesterol are actually your emulsifiers that bind your natural moisture factor, so your water phase, into your oil phase. Why does sebum have exactly 57% triglycerides? It's all got to do with Propionibacterium or Cutibacterium acnes. In your, this is very badly drawn, sebaceous gland, in addition to the sebocytes, which produce sebum, you also have presence of, I'm just going to call it CP, so Cutibacterium acnes or P. acnes bacterium. You also have this bacteria. Now, we've always been told that P. acnes or C. acnes bacteria is extremely bad. It's very ingenious. It lives in your anaerobic sebaceous gland, and the role of Cutibacterium acnes is to regulate and digest extra triglycerides so that your sebum is always 57% triglycerides with this. So this is very interesting because what we think is bad actually serves a very, very key purpose. There is a problem though. Cutibacterium acnes lives in an anaerobic environment. Your follicle, normally when it's not clogged or congested here, harbors oxygen, which means that it's not going to move there because it will suffocate and die by taking a fish out of water. So if I then create retention hyperkeratosis here, that means my Cutibacterium acnes, or used to be known as P. acnes bacteria, this is very badly drawn, but for example, it now moves from the sebaceous gland where it should be now into the follicle where it's not supposed to be. This is a problem for two reasons. Number one, Cutibacterium acnes loves a party. So as it begins to increase its infestation within the follicle, it then recruits another superficial bacterium called Staphylococcus epidermidis, and it now recruits that also into the follicle. So your acne is not just one bacteria, it's two bacterium, Staphylococcus epidermidis and also C. acnes bacteria. The two are reliant on each other. So if you increase the acnes, you then increase your presence of Staphylococcus epidermidis. The other problem at this point is the Propionibacterium acnes or Cutibacterium acnes. When it's in the follicle here, it digests extra triglycerides. So anything extra above that 57% is then processed. But the problem is though, when it gets into the follicle, it doesn't realize that any sebum that's already being produced is already being processed. So what happens is it begins reprocessing the triglycerides. With this, as it digests the triglycerides, it then separates it. So a tri-3-glyceride equals glycerol. So you then get separation into glycerol and into free fatty acids. It then eats the glycerol, but then because you have an over byproduct, it then begins discarding the free fatty acids. So what this means is inflammation. So as the bacteria increases and as it begins over processing the triglycerides, you then get inflammation which comes through. So that's what places physical pressure on the follicle, giving you the pain, enlarging, can't go up, can't go down because of this clogging and congestion here. With this process, what's also very interesting in the sebaceous gland here, you can imagine that it's a very, very fatty wall. So because of all the production of sebum, so it actually has a self-cleaning mechanism. And that self-cleaning mechanism is called a lipase enzyme. Because your sebaceous gland is so fatty, when your lipase enzyme, which is released as part of Cutibacterium or P. acnes bacteria's processing of triglycerides, it actually cleans up after itself. So it begins to clean off and eat away all of the excess grease that's sitting on the wall. So it's kind of like that if you've cooked a really fatty fry-up meal, that pan, if you just run under hot water, doesn't get clean. So you need to get out the hardcore dishwashing detergent to remove that grease. That's like the lipase enzyme. Your sebaceous gland is a lot like a pan, but your follicle is a lot like grandma's fine china. If you start putting such an aggressive cleaner on such a gentle fine china, you're going to strip it, you're going to braid it, you're going to break it down. So when you get a release of lipase enzymes, which should be good in the sebaceous gland and now in the follicle, it now attacks the follicle wall. And as it eats the follicle wall, this is the reason why you get post-acne scars. Rolling, box cut, ice pick. So it all connects in with your lipase enzyme here. So we understand that with bacterial proliferation, P. acnes bacteria does indeed serve a purpose and it's good when it's in the follicle. Sorry, when it's in the sebaceous gland. When it's in the follicle, this is problematic. But we also understand that despite the fact that it's the oldest living known bacteria that we're aware of, living species, it's anaerobic. So if you add oxygen, it kills it straight away. So even if you think of very old-fashioned beauty therapy treatments, such as high frequency, anything that adds oxygen in, or if you squeeze a pimple, I'm not always encouraging that it heals up quicker, it's oxygenation that kills that bacteria. So with Dermapen, with 1,920 channels per second, the oxygenation will kill the Staphylococcus, will kill the P. acnes bacteria or Cutibacterium acnes, and then that forces the reduction of the associated Staphylococcus epidermidis. So looking at acne now as part of combination therapies and as a major approach. So for sebum regulation, Dermapen, through growth factor release, will try and regulate what should be normal as best as possible. There is 2% salicylic acid in your Clearer Foam cleanser, which will help break down any excess clogging and congestion. Likewise, also, there's pyruvic acid in your Clearer Foam cleanser. And the pyruvic acid, again, will help with the physical thickness of the sebum. It's oil soluble, as is the salicylic. In your Clearer lotion used at home, salicylic and azelaic acid are both water soluble and will begin to digest through the thicker sebum. And then for your Uber Pro, you've got mandelic acid, but also retinaldehyde. to help with sebum thickness and quality. To kill bacteria, you've got 1,920 oxygenating puncture channels per second with Dermapen. For your NG collection clearer, you have an oligopeptide 10 that is specific for P. acnes or C. acnes bacteria and Manuka honey. Your clearer lotion at home, there's also tea tree oil added in. Your CliniPrep, with its natural hypochlorous and phosphoric acid, is one of the most ingenious products because in 15 seconds it's antibacterial, antimicrobial, antifungal, antiviral, and an antispore. To reduce inflammation, in your clearer foam cleanser, you have aloe vera, Centella asiatica, or tiger grass. In your NG collection clearer, what you will physically infuse into the skin during treatment, you have tranexamic acid, which is particularly good against red inflamed macules, niacinamide, copper peptides, manuka honey, Boswellia serrata. For your clearer lotion, you have a very key blend of herbal compound, essentially plant extracts to reduce inflammation. You have ferulic acid and copper peptides in Pro, and the hypochlorous in CliniPrep also reduces inflammation as well. To now encourage exfoliation to remove this. Dermapen, as we've seen before, epidermal growth factor, keratinocyte growth factor. Salicylic acid in your clearer foam cleanser, 2%. Bamboo particles, lactic acid at 5% contained in your microderm exfoliant. You then have in your clearer lotion for use at home, your azelaic acid, salicylic, lactic, glycolic acid. I also just want to add in your NG collection clearer has pyruvic acid for a micro exfoliation. Then you have your Uber Pro. As an addition for post-inflammatory hyperpigmentation reduction, not only do you have your regulatory growth factors from Dermapen, but cucumber, then tranexamic acid, kojic acid dipalmitate, vitamin C in your NG collection clearer, your blend of tyrosinase inhibiting herbal compound, and then of course in your Uber Pro, kojic acid dipalmitate, retinaldehyde. So each of these steps, although it appears many, of a simple Dermapen treatment, a Dermapen NG collection clearer plus Uber Pro does everything to handle all aspects. And then with appropriate home care, this now supports the whole process of acne triggers and activators. Looking at our protocols first, cleanse the skin always. Tri-phase cleanser or the clearer foam cleanser. You can exfoliate if you want. Always disinfect with your CliniPrep. You will use your NG collection clearer as your meso glide, always for acne. You use your Dermapen technique for most acne patients. You would be using your glide technique. I can't think of any acne patient that you would be using the Dermapen technique. Remove all of your treatment residue because blood has a higher pH. Your NG collection sits at about 6.5. Apply your Uber Pro. Wait 30 seconds to 3 minutes. So the same process we went through yesterday. Then neutralize with your highly active mask. Remove your residue, and then you can finish off with some NG collection clearer that remains, vitamin-rich repair, and then always cover, recover. I mentioned this yesterday, but particularly for patients who are concerned about what can and what can't clog and congest. When I teach the full day version of this class, I go through it, but it's called the Fulton and Figment Communogenicity Scale. As mentioned yesterday, these are not only the two pioneers of modern dermatology, but they're also considered the two most prolific acne specialists. The formal name for this is called the rabbit ear assay. And the reason why is because they apply pure forms of the products at 10% concentration and 100% concentration on rabbit's ears, and then determined the risk of communogenicity. What's very interesting with this, and you can download this very, very easily, it will give you around about 280 ingredients used commonly in cosmetics, and it's exceptionally surprising. So, lanolin, mineral oil, petrolatum, all came back as comedogenic or non-comedogenic. Lanolin, petrolatum, mineral oil, all came back as comedogenic or non-comedogenic? No. Absolutely impossible to clog, congest you. Impossible. They all came back as zeros. But coconut oil came back as a 5. What also came back as a 5, wheat germ oil. So many of these things that currently is a natural approach that people are using all came back as guaranteed will give you acne. What was very interesting as a mid coming back as a 2 and 3 was the red tinting agent that's commonly used in fake tan. So the instant color effect that you get, particularly seeing patients with a lot of clogging and congestion on their chest in weird places, it's actually the tinting agent in your tan. So that's the reason why that makeup these days no longer uses synthetic reds, food colors and dyes. It uses iron oxides because you won't get breakout from it.
So they create the tinting agent to tinting color.
It is called FDC, so food dyes and colors, or just DC, and then it will say red and then a number afterwards. So if you have a high rate of those, that's a synthetic dye, but it's also the same dyes that's used in, say, like confectionery. What makes a jelly baby red is an FD&C, but with this, a whole category of those, and you'll see it if you just Google the study, which ones in particular have a very, very high rate. So anything that's essentially above a 2 is going to be a comedogenic issue for most patients. So looking at our acne protocols here, we're going to treat every 2 to every 4 weeks, an inflammatory response, no blood, pink to red skin. Pink if it's comedonal, red if it's more nodular cystic. If you go over the top of an individual localized lesion, you will get some blood coming out of it, not a problem, so long as the whole face is not consistently bleeding. Your mesoglide is the MG collection clearer. I suggest automatically Uber Pro over the top. So don't offer as an upgrade, just offer this is the acne procedure at this price, which includes Uber Pro. You can then put a light on over the top. There's no benefit in putting a blue light on over the top, just go straight with the red light, and that will do oil disinfection, but also promote healing and anti-inflammatory. There is a problematic starter kit which the patient can use, but otherwise you have 3 non-negotiables at home. Clearer foam cleanser, it will not strip. It's a pH of 7.2. Cleaner prep, then your clearer lotion as a dual corrector and moisturizer in one. Then you can start adding in microderm exfoliant. If there's post-inflammatory hyperpigmentation, bright light, and then also the retinol active. So before and after cases, we did see these ones yesterday. So an acne stage 3, moving into an acne stage 4. Treatment for the body. Both of these are combinations of Dermapen, DpD dermaceuticals, but also Uber Pro. This is an extra one we didn't see yesterday. This one's a case study that we've actually been working on in the office. So this was the first patient to have the MG collection clearer applied. So this is following 3 treatments, but the combination therapy of Dermapen, the dermaceuticals, the MG collection, but then also the combination therapy with the Uber Pro.
Why did you formulate the acne?
The MG collection was formulated, it would have been about 2.5 years ago, I think.
So I don't know what
with that. So prior to that, we had formulated the original DpD dermaceuticals that use at home could also be used for infusion in clinic. I'm moving away from that because the MG collection is a lot more sophisticated. It's also a lot more concentrated and gives you a sterility, but also versatility of being able to mix, combine, and match them together. So we've now moved away from those traditional combination therapies, but using the MG. We've got through this topic relatively quick, but are there any questions that you have? Because I find that this one is one of the more enlightening topics where you go, wow, that's a lot of stuff that I didn't expect, or that's a very different approach to things. Everyone's very brain dead, I think.
It's not about the acne, it's mostly, I have a question about the scars, which is post laser. If the PMU was removed by laser, and then was stayed the scar. How to remove this? What protocols do you refer for it?
So you would follow, generally you find that you end up with like a small atrophic scar from that. So you would follow as if it was an acne scar, and then you would target that to make sure you support, particularly if it's the brow or it's the upper lip, and use an imprint technique to break that through to flatten out that area. You find it's very common for people to remove the eyebrow,
I do
scar, and then to place the eyebrow up higher. To give the illusion of a lifted look. So the same way that you would treat any atrophic scar.
All right. Thank you.
We have the option, I can either get through this next section and then we can break for lunch, and then it's going to be quite a fast day for this. You're happy for continuing?
Yeah.
No problem. So I want to explore the combination therapy of PRP, but then also mesotox. The PRP will be open for nurses or for phlebotomists in Ireland, but the mesotox protocols are still off-label, and this will only be able to be performed by a doctor. As we established yesterday, that when you apply solution topically, it's not ever breaking the skin's acid-factor. To then place the solution into the skin, our usual technique for mesotherapy is to use massage or point-by-point injections. This looks like this. Then if you use Dermapen 4, with 1,920 puncture channels per second, you actually end up with a far more effective distribution, saturation, and administration of the procedure into the skin. So of all of these options here, the most effective way to get something into the skin is Dermapen. But I also need to be honest and to say that this is also one of the more wasteful ways to get solution into the skin. If you only had 1 ml of solution, in some cases, you may be better placing it into the skin first with an injection to ensure absolutely no waste, and then distribute it over the top with Dermapen. So this links in again with needle psychology, which I mentioned yesterday. For some patients, they feel that they need to have an injection or see a needle for it to be a medical procedure. So it is possible to combine. So place your drug first. This is like we did with our SCAR protocols. Place the steroid first, then distribute it with Dermapen. So now this whole process here opens up opportunity, particularly for PRP, but then also for your nanofat. On average, your Dermapen is going to increase growth factor potential by around about 3 to 5-fold. PRP on a healthy patient will increase it by about 5 to 7-fold. It doesn't mean, though, that 7 plus 5 equals 12. It's all based on the patient's health. So as we went through yesterday with diet, that if you have an unhealthy patient, then you're not going to have a good quality of growth factors or a good quality of response. So for PRP procedures, and particularly for Dermapen procedures, if you want crystal gold for your PRP and for good growth factors, you want to re-alkalize the diet. You want removal of alcohol, removal of trans fats in the diet, low glycemic index diet, and also low inflammation diet, which means spice, alcohol, sugar. By observing these 2 weeks prior to treatment, you can then also influence the quality of the growth factors that you'll find within PRP. For this process, using a combination therapy, you're going to clean the skin first. Again, that is always crucial. Disinfect with your clean prep. Beforehand, you would have already drawn the blood. So I'm not giving you protocols for how to use a centrifuge or anything like that here. You would already know how to do that. You've drawn the blood, it's been centrifuged, and it's ready to go. If, and this is not necessary, but if for needle psychology, you want to do some localized injections, say particularly around the eyes, but bear in mind though, if you hit a vessel and you get a bruise, then your treatment's going to have 2 weeks down the line. But you won't get a bruise if you just use Dermapen. If you want to do localized injections around the nasolabial folds or the ventolabial folds, you can do that, but bear in mind that this is really more for theatre as opposed for efficacy. If you have a patient and you get very, very little PRP of the pure rich platelets and you've only got 1 or 2 cc's, you might want to inject just so that you minimize any waste of product. From this step, then apply your MG collection HA35. This one is your highest concentration of hyaluronic acid for a smooth, easy glide, but also with the MG collection HA35, the design of it means that it will not oxidize the PRP. It also won't dilute it down. So the PRP needs to remain within an airtight syringe. And then your MG collection is applied onto the skin like a glide, but it also will become like a sticking agent. So it's a bit like Velcro. So when you squirt the PRP onto the skin, it'll stick. So it means that as you treat region to region to region, you can then Dermapen that through easily. Squirt the PRP, remember it's running. So try and catch it with the Dermapen as best as possible, and then follow your standard Dermapen results. Vertical, horizontal, diagonal 1, followed by diagonal 2. You will need to draw a minimum of pinpoint blood. Your next step is any remaining PRP that you have is to continue to massage that in. There's indications, particularly from, shall we say, the godfather of growth factors. His name is Gordon Sasaki. He's based in Pasadena in the US. He's written clinicals for Dermapen World, but also independent clinicals. Sasaki has shown that the growth factors of the platelets can still absorb anywhere up to about 2 to 3 hours following treatment. So you want to continue massaging this in, even any PPP or platelet poor plasma, it's possible to do so. For me, I think as long as you can leave this massage treatment on the skin, you're going to look very shiny and feel very tight for as long as possible. So in clinic, if the patient says, I've got to go back to work, if you need to put a mask on, vitamin repair, cover, recover, you can do so. But preferably, if you were to do this in the evening, so the patient can go home and just leave it on their skin until the next day, this would be advantageous. So as long as possible, and then you can treat. The advantage when you do your treatments with PRP is that because of the increase of growth factor concentration, you can actually push your intervals as frequently as every 4 to every 6 weeks. So even if you're doing scar or rejuvenation work, instead of every 6 to every 8, you can treat every 4 to every 6. Here's how our treatment's going to look. So cleanse the skin first. Tri-phase cleanser. Remove all makeup, remove all residue. And of course, you can use PRP for the neck, chest, backs of the hands. And then superficial exfoliation with the microderm exfoliant. Following this process, you're then going to disinfect the skin with your Cleaner Prep solution. This slide really wants you to read. Although it comes in a pump pack, I think the spray is the easiest. So just simply spray it onto the skin, and then after the time period, if there's any excess, you can then just remove the residue with a sterile basic dressing kit. Once the skin is dry, You can, if required, as your optional step, you can use nappage or point-by-point technique to then inject the PRP into any localized area. So if the patient says to you, this is my concern area around my upper lip, this is my concern area around my nasolabial folds. But remember that this is placement. This is not actually the best way to administer. But if it keeps the patient happy, or if it means that you can add an extra 100, 200 euros on top of the treatment through the injections, then this is an advantageous way to create more profitability. It doesn't take long. Now you're going to apply your NG collection, HA35, onto the skin. I think for this, because you're going to need 2 hands, it's easier just to apply it onto the skin all over first. You're probably going to use 1 to 2 mils. So you're only using this as a sticking solution and a gliding agent to activate the PRP. It's not your complete mesotherapy. So I think all over the face is fine. And then you'll need to make sure that your hand that you've applied either swap gloves or dry it, because one hand's going to hold Dermapen, the other hand's going to hold the syringe. So that's the reason why you want to apply this nicely all over the face to give you a nice working area. Again, the syringe on the end of this, the needle, is for theatre. With the PRP, make sure, however, that it is in a closed syringe. So if you've got a little lock, you can still use a little lock syringe without the needle on it. Squirt it, massage it through, distribute it, and then we're going to apply Dermapen over the top for then infusion. So vertical, horizontal, apply more product as needed. Diagonal 1, followed by diagonal 2. So if you feel that there's not enough product, just simply squirt some more. The average patient probably should give you around about 5 to 6 cc's of PRP for a healthy patient. So you've got a lot of product to play with. So this means particularly following treatment, you can continue on massaging that in every 10 minutes if they want to hang in the waiting room or if they want to stay in another room, and then you can completely maximize until the PRP is all disappeared. So distribute, catch, massage through, vertical, horizontal, diagonal 1, and then diagonal 2. So you can see that not much changes with these types of procedures. It's all nice and standard with your glide technique, and particularly for fast administration of PRP, it's a lot more comfortable than if you were to do 300 injections. It's a lot less traumatic on the skin because there's no bruising and the patient's not as puffy as if they were following a traditional injection technique. But on the other hand, if you need to do a few injections to make it look like a medical treatment or to place your product, you do have that capability. So we're looking for a visual endpoint with pinpoint blood as a minimum. We're now working on the cheeks. And then the best part is precision work around the eyes. So without an injection, this means that you can really target through the tear troughs and the actual eyelids themselves. So even with your treatment yesterday, you obviously found that the eyes are weird, but not painful. It's just a strange sensation.
Why do you treat the tear troughs?
Because through the tear trough here, particularly, you can get fine lines that will come through this, particularly for people who funny lines, people who create that squint effect. It's not my natural movement for that, but with people like that, they'll find that they get funny lines through this. So it's a whole area where botulinum toxin is injected at the top of the nose, but it's not going to target all the lines through here. And particularly if someone is slightly hooded through the eye area, you can create an excellent lift firming. So you can see this is the perfect visual endpoint. Rather than squirting the PRP directly into the eye, which is going to sting and be irritating, put it onto the forehead and distribute it. But you can see how close we get around the eye. Now through the tear trough, and then up onto the actual lids themselves.
Many times I saw that someone is using circular movements. Then
the reason why I don't recommend circular movements is I want you to listen to the marker on the board. Now listen to this. Can you hear the difference? Maybe not. But with this, I want to show that this is far more methodical and fractional. If you do circular movements, it's just going to cut through the skin. So now we finish up the top lip. For me, the thought of my own plasma sitting in my mouth is a scary thought. So following treatment, now we've got options. First option is to massage in any remaining solution that you have. Sasaki has a very interesting technique. This may or may not be legal here. So I call it the red light technique. So any remaining PRP or PPP actually gives in a closed syringe, no needle, to the patient, gives them a box of gloves and says every 20 minutes for the next 3 hours, massage this in. Many councils may not allow that. So otherwise, you could have the patient sit in your waiting room or another room, and then you or your colleague every 20 minutes can go back in with a new pair of gloves and massage more product in if the patient can stay for an hour or a little bit longer. Otherwise, the more you massage in and continue this, the more will physically go in. So the better the health, the better the quality of the skin, the better the response is going to be. So you can see a perfect color and a perfect infusion there. If you can't leave on for as long as possible, then you can go into your standard post-op. So preferably, the longer you leave the PRP on, the better the result's going to be. But otherwise, once you are past that point, then you can use your vitamin-rich repair and also your application of your shear. Otherwise, they can then go home, or in clinic, if they want the full procedure, you can then use the hyperactive 3D mask and then continue on as if it was a standard treatment. But what I want to say is the longer you can massage and leave the PRP on, the better the results are going to be, but the patient's not going to look so good when they leave the clinic. So PRP combination therapies, we see success in all of the alopecia treatments I'm going to share with you today are going to be with PRP. We see here for stretch marks, so a very, very large surface area, particularly with Dermapen, it's a lot more comfortable than doing 200 injections. We even see success with PRP for treatments such as recalcitrant melasma. So all of these combination therapies can be an option. So the advantage of this, depending on the device that you use and depending on your centrifuge and your consumables, this could turn your €300 Dermapen treatment into 600, 700, 800 for this. So this gives you even greater profitability. But at the same time, if you were to perform a Dermapen procedure, MG collection, Uber Pro, you can still start attracting, even if you use LED light, at €400. So you can start attracting a significantly higher price point as well. For the mesotox protocols, these are an off-label system. And the reason why is because the companies which produce haven't done any formal studies and they've yet to commit to this. So this is an option, but this is purely a guide based on our experts who have worked with this technique. So this is their opinion. This is not the opinion of the companies which produce botulinum toxin. This is also not a formal opinion of Dermapen World. This is just a suggestion. The concept of mesotox developed out of practitioners using botulinum toxin more superficially, where there is no muscle, But what they found, particularly when microneedled into the skin, that it would close the appearance of open pores. It would be able to treat very, very fine lines, particularly around the periorbital area, which the injections weren't treating. So typically the injections will work from the ocularis outside, but not the inside through this section. But it was also treating for papulopustular rosacea and also creating what the South Koreans refer to as being a glass-like skin. This is all off-label, but cleanse the skin, then disinfect with vinaigrette. Rather than reconstituting your botulinum toxin vial with saline solution, what you're going to do is reconstitute it with your NG collection, HA35. This is going to have a different approach because all botulinum toxin practitioners will talk units when you normally inject them. What I need them to do is to now talk milliliters because it's not as precise as 2 units here, 2 units there. So you're going to reconstitute, instead of saline, you're going to reconstitute this with your NG collection. Depending on your brand, depending on the size of your vial, will then determine how much of the NG collection you've got to reconstitute. So for your main mass market brands, it's going to be either 1.25 mils or 2.5 mils. So this is all the major brands that exist on the world market. You'll notice that the vial sizes are normally 50 units to 100 units. Note, however, that the product Dysport, otherwise known as Azalua, has a different dilution, but also a different measurement system. So just identify that for those who are working with Ipsen or Galderma here, which is the product called Dysport, or the product is otherwise known as Azalua. But otherwise, for your standard other common brands from Botox Cosmetic to Vistabel, Bocatur, all of these are generally working in either a 50 unit or a 100 unit. 50 units equals 1.25 mils of HA35 plus, and then your 100 units equals 2.5 mils. So with this process here, once you've reconstituted it, you're then going to apply the solution topically to your key treatment area. Let's think smart though. If you have a vial that is only 1.25 mils, you only have 1.25 mils of product to play around with. That's not a lot of product. So we need to keep this affordable, but we also need to use very, very small amounts. That's the reason why I don't talk units here, because units is not going to help you, but understanding that you only have 1 and a bit mils or 2.5 mils of product to play around with gets you the focus that small amount equals your best result. Typically for an area such as the eyes here, you would be looking at around about 1/4 mil for both eyes. If you want to treat, say, open pores on the forehead, down the nose, you might be looking at 1/2 mil of product. So you're going to need to charge based on the amount of mils that you use, as opposed to trying to think units with this. So with this process, you apply your NG collection, same way as your standard lubricating glide. Then you're going to dermapen the area, looking for a minimum of some pinpoint blood. You don't want on whole moderate blood, but you just want to know that it's getting into superficial dermis. Massage any remaining solution. So this does waste the product a little bit more. And then you can remove your residue and then apply your vitamin-rich repair and your recover over the top. It's possible to do a full face, but you would probably need around about a 100 unit or 2.5 mils to do that. So it's possible to do large areas, but bear in mind that this is going to be expensive. That's an entire vial of botulinum toxin at 2.5 mils with this. So just be aware of that cost, and just be aware that also once you reconstitute it, generally for your brands, it has about a 48-hour lifespan. Check with the supplier. So you'll need to put it back into the fridge, and then you've got to use it up within around about 2 days for that. This is only just a guide, so Dermapen World does not endorse this as an official protocol. This will help you out, but likewise also if the product has already been reconstituted, the only brand that does that is called Initox by Meditox. It's a South Korean company. This will not be appropriate because you will dilute it too far down if you use your MG collection. But also notice that the difference of Botox and Dysport or Azalea are on different measurement systems. So when you look at this, an entire vial of Azalea, which is this, is 0.63 mils. So you're not looking at 1.25, so don't over dilute it down because of your brand. Shall we take a break for lunch now? And then we will go into our final topic. I think this topic probably will take us about half an hour, 40 minutes, and then we'll have an early finish.
Yeah.
Okay, so let's move on to our final topic for today, which is going to be treatment of alopecia. For this master topic, there are going to be some drug combination therapies, but otherwise we've got a pretty straightforward protocol because you'll find that for 90% of cases, you're going to be incorporating what we've covered with PRP as part of your combination therapy itself. So just some basically hair facts. We understand that hair is a filament that is designed initially or anthropologically to essentially keep the body warm. We've got around about 100,000 hair follicles on the head itself. For your alopecia treatments to be very, very clear, so that you're very, very clear with the patient, if your follicle is dormant or the follicle is not there, you cannot treat with Dermapen. You cannot treat with any of these protocols. So you must have an active follicle in order for any of these treatments to work itself. So when we look at hair growth and hair development, the hair on our head we commonly refer to as being capillary hair, but otherwise we will refer to hair either in its vellus form, which means that it's lighter in color, it's smaller in size, and we would commonly refer to that as maybe being peach fuzz for English. And then during puberty, so the same hormones that will be behind sebum thickening are also responsible for follicular maximization. So the role of testosterone and the role of 5-androstenediol-317 not only enlarge the sebaceous gland, but as they enlarge the follicle, that therefore means that you can enlarge hair growth. So this is where we see the role of terminal hair transition. It's darker and thicker. My easiest example for this is a bit like a pot plant and bonsai. So if you have a big pot plant or a big follicle, you can sustain big growth. But if you only have a small pot plant or bonsai, you can only sustain small growth. So this is the reason why if you look at the face, particularly for guys, as puberty comes through, the follicle around the beard is larger, which means it can sustain a larger hair by comparison to where the follicles are smaller, say underneath the eyes or on the inner cheeks, which means that there's still hair there, but this is where you only get the vellus hair as opposed to terminal hair growth with this. Hair growth stages you would be familiar with when it comes to hair removal, particularly through laser and also through IPL. I don't want to recover that area, but what I want to do is just pre-warn you so that patients' expectations are met, particularly for cases of androgenetic alopecia or male pattern baldness. So anagen phase, which is your hair growth phase, 2 to 7 years you have of growing time, anywhere up to around about 45 centimeters for capillary hair growth on your head. Otherwise, with the body, it will cap itself generally at a few centimeters with that. Because of this growth phase, and because 80 to 90% of hair is in this growth phase, if you are going to treat combination therapies, particularly with minoxidil for part treatment of androgenetic or male pattern baldness, or for telogen effluvium, For the first 6 months, the hair growth phase needs to get into a consistent pattern. So normally by about month 6 of treatment, the patient will find that all of the success you've achieved then starts reversing. So with this, the patient's going to call you up and be very, very angry and very, very upset. However, give it another month or 2, and then from our catagen and telogen phase, then getting into regulation, as we then move back into anagen phase, then you will have a consistent hair growth. So catagen phase is a very, very short phase where essentially we've got the hair stopping its growth and it's getting ready for removal. So then we have telogen phase. The telogen phase is classified by club hair. That hair then falls out. Then during this time, we then get into preparation for the new hair growth. So once that shedding of the hair, 50 to 100 hair a day is relatively reasonable. But if you're seeing significant clumps of hair loss, then we will assess as to why that is occurring. And then we move back into anagen phase for this. So having a look at what we can treat and the forms that we do have success for. Again, I cannot stress any clearer. You need to have an active follicle. So the simple example I use for this is if Prince Harry comes in, there's a potential opportunity. But if William comes in, there is no chance that you'll have any success with that. So the only option for that is going to be a hair transplant for this. So you need to have an active follicle for any of these procedures to work. Tractional alopecia is where we have pressure that tightens the hair over a longer period of time and then snaps it. The most common reason for this, particularly for African cultures or cultures where there is hair braiding and hairstyles, is going to be pressure that's put on from hair extensions, from weaves, but also tightening from cornrows, dreadlocks, styles, and things like that. But we also see tractional alopecia, very, very common. Sports industry, or where people are wearing hats. Where we also see it very common is religious headwear, where clips are not changed or moved around, but we can also see it in cultural activities where the hair is pulled back extremely tightly from a ponytail to a bun, so on and so forth. This is where you have snapping of the hair over a long period of time. So if you were to look at the hair that's falling out, you would notice that the hair is broken. There's no root on the end of it. By comparison, if you were to pluck a hair out, or if you were to wax hair, where you would see a little bulb at the end. If you snap the hair and create such tension and tightening over a long period of time, that then becomes trauma. When you have trauma, that will then be replaced with scar tissue. So the most severest form of tractional alopecia is cicatricial alopecia. So within the hair follicle here, it now becomes mutated. So instead of looking like this, because of the constant pulling of this, it now looks like this. So what's going to happen is either the hair is going to get stuck and you're going to have issues with ingrown hairs, you're going to have issues with growth of the hair, or alternatively, scar tissue is just simply going to close it off, and then you're going to have no hair growth. So if you get in early enough, you can achieve success. This is too late. This is also too late. You can see that with androgenic alopecia, that there is vellus hair through this area here. That means that there is still an active follicle. But in the center here, there is no active follicle. So this is hair transplant material. We then have active capillary hair through this. The androgenetic alopecia, male pattern baldness, but it can also be female pattern baldness, you have a process of reversal. Due to a sensitivity to 5-alpha reductase, the same enzyme we covered with acne, which manages hormone conversion, which then turns the hair from vellus into terminal. The sensitivity then creates a process of reversal. So you go from terminal to vellus. So you can see the vellus hair around the edge here, and then from vellus, it will then be shed, and then the follicle becomes dormant. Telogen effluvium is becoming a big topic at the moment, particularly with COVID. It's essentially your reaction to stress, your body's response to certain medication. How this is characterized is follicular minimization. So you go from big pot plant to bonsai. When you have bonsai, that means that the follicle cannot sustain long, thick, luminous hair growth. So as a result, the hair becomes exceptionally thin and the hair can also become very, very patchy. You need to have stability as to why you have that triggering source. So to fix that, stabilize it, then we can see results. The alopecia areata is an autoimmune disease. So the body views the hair and views the follicle as being a pathogen and then constantly sheds it. In order to achieve success to this, you need 6 months of stability. If there is not 6 months of stability, then any results that you do achieve are going to be compromised. So the patches will change very, very frequently with these patients. As such, many doctors will incorporate steroid combination therapies to try and achieve some level of stability and success, but absolutely stability becomes important for longevity. Alopecia totalis or universalis, you'll notice that I've crossed them out. There is absolutely nothing in dermatology, nothing in aesthetics that's going to fix or solve this. So totalis is where you have no capillary hair on your head. Universalis is where you have absolutely no hair on your body at all. The example I can think of is Matt Lucas from Little Britain. So that's an example of universalis. So no lashes, no eyebrow hair, no head hair, no hair absolutely anywhere. Having a look at triggers, activators, and causes. First, anagen hair loss. With this, if the hair is anagen phase during that growth phase and it's snapped off, you'll typically find that the hair has no root on the end of it. You'll also find that the hair may look stretched, or you can physically see a snapping point. So for example, the reason why many people think that if you shave yourself, that the hair comes back thicker and shorter is because the hair naturally looks like this. But if the hair is shaved, it cuts off that tip. And likewise, if the hair is also snapped, you'll notice that the hair won't have any fine end, and the hair also won't have any roots on the end of it, which is what you would see if you were to pluck the hair out. With anagen hair loss, these conditions will include alopecia areata. So quite simply, the hair is just going to shed very, very quickly, or the hair will snap. Chemotherapy, certain drugs or medications will promote further hair loss, but this can also be when there's major pressure on the hair. So again, we're looking for tractional alopecia, which is surprisingly common. Something as simple as a gym hat, something as simple as religious headwear, something as simple as hairstyle, not changing position of a ponytail or not changing position of headbands. Hair shaft abnormality is what we've got here. So this is really your story of tractional alopecia leading into cicatricial alopecia. Tractional is a very simple process of just changing position of clips, changing position of headwear, changing position of pressure, but also for things like hair extensions, making sure it's not always applied into the same area. Once you move into cicatricial alopecia and there's scarring looking like this, the odds of your treatment success are going to be quite low. For male-pattern baldness, we spoke about 5 alpha reductase imbalance. It's more about a sensitivity to this. So what this sensitivity does is then affects the conversion rate of testosterone into dihydrotestosterone. When you affect this rate, it then creates a process of reversal. So instead of going from vellus to terminal, we go from terminal to vellus, and then we move back into the follicle becoming dormant. The final area for consideration is called telogen effluvium, or club hair loss. So certain medications can make this create a full hair loss, but you'll notice that there is a little root on the end of it. This can also occur with conditions such as bulimia and also anorexia nervosa. What you'll find is that you have club hair loss on the head with a small root, but then the body hair begins to grow, so you have an increase of vellus hair. If there's rapid changes in weight, if there's rapid changes in stress and in health, then you will find that this can affect and create telogen effluvium, which will either be thinning or follicular minimization, and then that can be followed in severe forms of club hair loss, which means that there's physically a little root on the end of it. So Dermapen will work well for tractional alopecia on the condition that the patient updates how they treat their hair. So whether that, again, is movement of hair extensions, making sure that positioning of clips or headwear, making sure also that hairstyles are changed frequently. For cicatricial alopecia, only very, very early stages will we have success. Otherwise, once it's created follicular mutation, you're not going to get any success with it. For androgenetic alopecia, you must have an active follicle. You must also commit lifetime to a follicular maximizer, which is the drug minoxidil. If your patient is not willing to commit, then there is no point doing the treatment because it's going to be very, very short-lived. For alopecia areata, you will require in some cases a steroid combination therapy, but for longer term growth and regeneration, you need 6 months stability. And I would say that's the case for any autoimmune disease. For telogen effluvium, again, you need stabilization. Whether that's medication, whether it's health, whether it's stress, there needs to be some level of understanding what the trigger is, finding the balance, and then you can achieve some success. Dermapen in this case is a facilitator. It's not your sole treatment. So I would never recommend that you encourage Dermapen as being an alopecia procedure just as a standalone treatment. It's not. So whilst Dermapen will promote vascular endothelial and platelet-derived growth factors, which in turn will promote more extensive blood flow and vascularity to the follicular bulb, which allows the movement of growth factors, but also hormones to then sustain positioning of the bulb within the follicle and then allow nutrition for physical hair growth. It's not going to necessarily give you everything that's required to guarantee the hair growth itself. So really, it's more about circulation as opposed to physical hair growth. In the case of cicatricial alopecia, for early stages, the mechanics may break down some of the scar tissue, but really the effect of Dermapen is the fact that with 1,920 puncture channels per second, you can now create infusion. So this is your key area as a facilitator. Your results only last as long as you keep consistent with the treatment, but also with the drug combination therapies. If you are not consistent with this, then your results are going to be very short-lived. The patient success stories that I will share with you are just Dermapen and just PRP, but for longevity of those results, the patient will need to support in many cases with some other combination therapies. A huge area of development is eyebrow growth. So eyebrows change roughly every 10 years with shape, thickness, and what people are really after. You can Dermapen the eyebrows, that's not a problem. You can also use that with minoxidil, daily applied. You can also use that with PRP. There is a drug that is specifically designed initially for glaucoma, and then it was turned into a drug that would enable lash growth and eyebrow growth. The drug is called Lumigan, which is its form for glaucoma, and then the form of this drug, which is then put into a mascara wand, is called Latisse. This is owned by Allergan. The drug itself is called Prost. With this drug, it will provide hair growth when used every single day, but only so long as you use the drug. If you stop using it, you don't get hair growth. Note that there is a risk with this product of stimulating melanocytes. So some patients will find that they end up with darkness through their brows and pigmentation. Be conscious of this, and also can find that there is darkness around the lash line. Do not dermapen the lash line. You can dermapen the upper eyelids, you can dermapen around the eyes, but just not on the physical eyelashes. So the success we see with treatment is really a facilitator of PRP particularly, but also for vascularization. From a treatment perspective and looking at combination therapies, which options do you have? The hair market is very unregulated, which means that there are a whole lot of options when it comes to mesotherapy and a whole lot of options of miracle lotions and potions, and not a lot of these have clinical evidence behind them. So with this, I'm going to take a more medical approach of what is guaranteed to work. The most obvious combination therapy is PRP. This is clinically proven, this has been studied, and particularly the combination with Dermapen itself has also been extensively studied to deliver results. How long those results are going to be, particularly for telogen effluvium and the androgenetic alopecia, are going to be determined by the patient's use of minoxidil at home every single day. Dutasteride and finasteride are new up-and-coming developments for the hair loss market. Finasteride is a drug that initially was designed to stimulate hair function. The problem is with finasteride, the old dose used to be 4 milligrams a day, taken by males only for male pattern baldness. It's not prescribed to females ever. Is that generally figures as high as 80% of males were experiencing erectile dysfunction whilst on the drug. So then they would stop taking it, and around about 40% of the 80% of patients would have permanent erectile dysfunction. The other issue was then also sterility. So the problem is that many doctors would not prescribe it for patients between age 20 and 35, baby-making years with this. And however, the issue is that this is the time when most of their hair is falling out. There's other controversies with finasteride at higher doses, which include not only longer-term sterility and erectile dysfunction, but also psychosis. So finasteride's undergone many, many changes. So rather than high dose over a longer period of time, patients are now taking a lower dose, around about 1 milligram per day, and we're seeing a lot less complications. Finasteride has been difficult not only because it's an oral medication, but also trying to get it into a form, because it's oil soluble, to get it into the skin. So we now have updates where finasteride is now being available in a mesotherapy form, but it will be on prescription. For less complication, you can use the cousin of finasteride, which is called dutasteride. And again, this is going to be on prescription. The dutasteride, just for patient feedback, it's a very, very thick gel, and whether it's needled in or whether it's injected in, it's quite painful for patients, but it's very, very effective. So from PRP, which is non-prescription, dutasteride and finasteride in their mesotherapy forms will be on prescription. Otherwise, you can look at amino acid complexes with this. With amino acid complexes or vasodilators, there's many, many options on the market. There was a very interesting study which came out, I think, around about 9 days ago, and it was very clear that biotin has no effect on hair growth at all. Never did, never has, no point in using it. So many common agents that we associate with hair growth, from caffeine to biotin to vasodilators such as tea tree oil, eucalyptus, there are no studies on any of this stuff. So once you start getting into amino acid mesotherapy land, you need to look for something that is medically, clinically evidence-based and proven. That is the reason why we do not produce a hair loss product, because If we do, we need to get into prescription land. We need to get into pharmaceutical land because quite simply, there is nothing on the market that's going to work that we can use unless we get into prescription. Another option for only male pattern baldness and only for telogen effluvium, this will not work for anyone else, to support your treatments is topical minoxidil. Minoxidil you can find in some mesotherapy solutions, but many practitioners are not a fan of using pure minoxidil as a microneedling medium. The reason why is minoxidil's origins was for blood pressure. And if you have too much product go into the bloodstream, then the risk is going to be that the patient's going to pass out. Minoxidil is a follicular maximizer. So the two forms of alopecia where you have follicular minimization is either the early stages of male pattern baldness or it's telogen effluvium. So for these two, you need application of minoxidil every single day from once to twice a day. The minoxidil is an easy spray lotion that's simply sprayed through the hair. For male pattern baldness, they may wish to also supplement this with either minoxidil tablets or alternatively 1 milligram of finasteride medication. That takes us into the new area that for male pattern baldness, oral finasteride. 1 milligram tends to be the preferred dose these days, which means that it can be used on younger patients, but again, you need to get in early. Once the follicle is dormant, none of this will work. For alopecia areata, you can have a corticosteroid injection. The preferred steroid is the same one we used for scars, which is the triamcinolone acetonide. So the injections through this will prevent an inflammatory response. Preventing inflammation and signaling means that the process of pathogen attack slows down the body's immune response where it's attacking the hair follicle and then creating removal. A really handy trick that will work to facilitate any of your PRP treatments is red LED light. For DP dermaceuticals, we do not produce an LED that is specific for the head, but we do produce one that is for the neck and for the chest. You can actually wear this one like a bonnet. It looks very much like a handmaid's tale, but you can actually wear this one on the head and leave it on for 10 minutes following treatment, and that can serve as an effective combination therapy. But with red light, you need to be regular and consistent with procedures, which roughly means for your first course, 3 procedures a week for 4 weeks. So continuity is important. The other and the most obvious combination therapy that you can do, particularly for tractional or cicatricial, is change positioning. So whether that is your hairstyle, whether that's religious hair wear, whether that is going to be hair extensions or additions, whether that is something as simple as a gym cap rubbing against the temples, a construction cap, or whatever that's going to be conscious that you change positioning, and then we can reduce a lot of the pressure and tension. The treatment protocols are almost identical to the ones that you were using for your PRP. Only what changes is your technique with your Dermapen procedure. It's going to be difficult to glide, particularly if there's a full head of hair. So this is the early stages of alopecia areata. So we start to see losing of hair around the temporal region, and then also the front of the scalp, and then thinning of the hair. So this is a good time to get in, because many practitioners will look at this video and go, hold on, this guy already has long hair, what's the problem? It's not the fact that there's long hair, it's not as much long hair as what he would like. Likewise, also, you see how the hairline is receding, but the thinness of that hair. So this is the perfect time to get in. Disinfect the area with Cliniprep. If you need to inject to keep the patient happy, you can do so. But this step of needle psychology is really just theatre. your Dermapen will give you a better infusion. What I find with patients is the less hair they have, the more painful the injections are. The more hair they have, then the injections are far more tolerable. That's also the case for Dermapen as well. You will then apply either, depending on price, you can use the original Hyla Active, which comes in a 250 ml airless pump. It just means that you can burn through a lot more product if you're going to be treating a full scalp. Otherwise, the option is to use the MG Collection HA35. So with this, you have two options for your facilitating glide. You want to apply enough that when you squirt the PRP, it will stick. So it doesn't end up on the floor or doesn't end up just making the hair wet. Once you've applied this, massage that through, you will squirt the PRP, and then you will use your Dermapen to distribute the PRP into the skin. Your technique is going to be different. For your standard techniques, you're using gliding, which is vertical, horizontal, diagonal 1, diagonal 2. If you have a patient, this is a really bad drawing, but work with me. If you have a patient who's got a thick head of hair, trying to do a vertical, then a horizontal, diagonal 1, diagonal 2 is going to be very, very difficult. If you have a patient with long hair, this is going to be hard. So what you're going to work is short inflections, which is going to be how this will sound with your device. Full speed. So you can hear that bounce and you can hear that inflection. You're going to find it very difficult for most patients to be able to do this. So a small inflection. That will also help to separate the hair and it creates more comfort for the patient. You need moderate blood as your visual endpoint. The reason why is because when you look at your follicle here, this is your epidermis, this is your dermis, this is your hypodermis. So the blood flow that's delivering nutrients, hormones, and growth factors to sustain positioning of the bulb and the follicle is coming through from the hypodermis. So that means you're going to need a moderate blood coming through. When you've finished, similar to your PRP procedures, massage in as much PRP as you possibly can. Keep that process going. If and only if for malpattern baldness or telogen effluvium, you can massage in, finally, some minoxidil solution as part of the end of the treatment. At the end of the treatment, you can then also apply a red LED over the top for this. So you've got some options to extend. If you are using PRP, you can make your treatment intervals as close as every 4 weeks. If you've got a respectable, clinically proven, evidence-based mesotherapy that's on prescription, dutasteride, finasteride, even a minoxidil blend, you can still probably treat every 4 weeks. Having a look at the treatment itself. Here we go. So this is the early stages of androgenetic alopecia. Disinfect the area. The spray with Cliniprep is so handy for this area. Just removing excess residue. This is really just for comfort so the patient doesn't feel anything dripping down their face. You can begin with some nappage or point-by-point injection technique, but again, this is really just for theatre. Dermapen is going to be far more comfortable. So if there's any key areas, you can see through here the vellus hair. So you can see that he's undergoing a process relatively quick with that hair changing. You can use the hyperactive, particularly over very, very large surface areas, or otherwise you can use the MG collection HA35. This is a requirement, otherwise the PRP will not create an effective contact. Squirt the PRP through. Generally, you should get about 5 or 6 cc's of product from a healthy patient, and then catch and distribute with Dermapen. So you can see that it's a bounce inflection. If you try doing long strokes, it's uncomfortable, but you'll also find that it will get caught in the hair. As opposed to a roller, many practitioners will say to you, hold on, aren't you going to be pulling the hair out? A roller will, because as the hair gets caught around the barrel, it will take hair. But for Dermapen, if you use a bounce inflection technique, it will give you movement, it will give you capability to work through the treatment area, but you're not going to pull any hair out. So short inflections. You're looking for moderate blood. Most patients will find that it's a scratchy sensation. It's not particularly painful unless the patient already has a lot of hair loss. And realistically for those patients, it's probably too late. In this case, after massaging in PRP, you can then use the PRP to remove any thickened blood or dried up, and then we finish up with some minoxidil. Otherwise, if patients have larger patches and it's not androgenetic alopecia, you can use some vitamin-rich repair and recover. For before and after images and for case studies, you need to be very clear with patients that hair growth is not going to occur overnight. So in the case of these 2 patients here, the positioning, the reason why for tractional alopecia are clips to hold a hijab in place. So both patients are Egyptian. The before and after the 3 treatments is not world-changing dramatic, and it never will be. And the reason why is not because the treatment's not worked, the treatment has worked, but if you consider how thick and how long the hair is down to the waist here, 3 treatments is not going to give you waist-long hair. So you've got to be clear with the patients that it's gradual. You have to activate hair growth. It will then move from vellus into terminal, and then it has to grow. So for this patient, they would need to change positioning of the clips, but we can see we started the process. This is PRP and Dermapen. This is my definition of moderate blood. So this is a nice, good visual endpoint. And again, we see a slow but steady regrowth, but again, you're not going to get 20 centimeters overnight. Now looking at telogen effluvium, your issue is that you need to thicken up the existing hair as well as replace hair that's fallen out. So again, for many cases, you're not going to see instant fullness for at least a 6-month time period. This is telogen effluvium after 4 treatments, but the hair is very long. So you begin to see that it's thickening up and begin to filling in. This is a mild form of telogen effluvium, but you can see that as the patient's hair grows, and with curlier hair, it's disguising a lot of it. And again, for telogen effluvium here, we begin to thicken it up so that there's more density to the hair. For male pattern baldness, these 2 patients here, this is female pattern baldness, male pattern baldness. I just want to highlight the pioneer for microneedling in PRP, which is Dr. Joseph Greco. He's based in Florida in the USA. In counterpart with his colleagues, Schiavello, who's based in Milan, they really were the pioneers of microneedling and PRP for alopecia procedures. Way back in this time, I think this was from around about 2014, they didn't know what your intervals would be. PRP was still relatively new to the market. Microneedling with an automated device was still relatively new. we didn't know what the treatment intervals should be. These two cases are from the original test studies, and so they were performed at 3-month intervals. This is only 2 procedures, no other combination therapy. We see success. But Greco then reassessed a lot of his work and then said, 1 month, every month is going to be a better time period. But for all of these cases here, it needs to be supported with minoxidil. Ongoing, you stop, then it's all going to come back. As I mentioned before, month 6 for minoxidil, normally as the hair growth phases begin to synchronize, you're going to notice on month 6 that you're going to see a lot of hair falling out before you then see a longer lasting, more regulated growth pattern. Bear with for that 6-month time period, and then by month 7, month 8, you will then have a consistent growth. This patient here from New Zealand, 5 procedures, treated every 4 weeks with PRP, an extremely satisfying result, but it needs to be backed up with minoxidil because the body is naturally going to want to minimize that follicle. Finally, we look at alopecia areata. You need stability. So in this case, we can see that this is without, steroid injection, but you can see the vellus hair. It needs to be stabilized for 6 months though, and then the process of vellus hair turning into terminal and growing still might take another 6 months. We see for this patient, I think she was about 15 years old already, the hair is long, so it's able to cover up. But for these patients, the doctor may consider using some steroid injections in order to create longevity. But otherwise, for simplistic combination of Dermapen plus PRP, we can achieve some success. That's my alopecia topic. It's a very quick one because it really relates into what we've done with mesotherapy and what we've done with our PRP combination therapy. But you'll also find that you need to support it with minoxidil, particularly for male pattern baldness, which will be one of the most common reasons as to why you're going to have patients come in. So that concludes our theoretical part for today. We've got through it a lot quicker. So at this point, we can take a break, and then we've got a patient coming in 7 minutes, and I'll get set up for our treatments. And for those watching online, we will film the treatments and get them sent to you as well. Any questions?
No, it's
a pretty simple topic. It's not possible to stretch out.